start us off. Thank you.
Sounds great. Welcome, everybody. Good morning, and welcome to the final P&T committee for 2024. I am Kavita Chawla, the chair of the P&T committee. I will now read off the names of the participating attendees. Please say here when I call your name. Peter Barquette.
Here.
Good morning, Peter. Laura Bestie.
Here.
Hi, Laura. Gregory Hudson.
Here.
Morning. Zoe Taylor.
Here.
Hi. And Christy Weiland.
Here. Good morning.
Good morning. All right, and then we have our Healthcare Authority members. We have Nania Connor,
Hi, good morning.
Amy Irwin,
She will not be joining us today.
okay, Luke Dearden.
Good morning.
Hi, good morning. Lita Vasquez.
She might be joining later. I don't know if she's joining, but she may be joining later. Yeah.
Okay, all right. Elizabeth Punsalan.
Here.
Hi, Donna Sullivan.
Oh, she will not be joining us today.
No, okay.
Yeah.
Marissa Tabile.
Here.
Hi, Marissa. Ryan Takatomo.
Morning, I'm here.
Morning, Ryan. Joey Zarate.
Good morning.
Good morning. All right, and then we have our labor and industry members, Jamie Mai.
I don't know if she will join us today.
Okay. Then our DURP presenters today are Wesley Lindsay.
Good morning.
Hello, and Shannon Robolino.
Good morning.
Good morning. Got our Prime Medicaid administrators presenter, which is Nina, of course, Nina Yoon.
Good morning. Hello.
Hello. And our managed care representatives. So we've got Greg Seamus from Molina, Heidi Goodrich from Molina, Petra Eichelsdorfer from United, Omar Daoud from Community Health Plan of Washington, and Jeffrey Natividad from Community Health Plan of Washington. All right, so now Nani will go over the meeting logistics.
Yes. Hi, the committee, excuse me, committee and presenters can mute and you unmute yourself at any time, but please mute yourselves when not speaking to limit background noise. Presenters, please share your webcams while presenting. Committee, please share your webcams during discussions and motion consideration. For stakeholder participation, the chair will read the list of stakeholder names who pre-registered to speak. We will unmute you. After the share, we'll ask if there are any other stakeholders. If they are, please raise your hand. We will call upon you and unmute you. You can also use the Q&A box. We'll address your questions during the stakeholder time. If you did not fill out the stakeholder conflict of interest form, please answer the questions we'll post on the screen. Your 3-minute will start after you answer the questions. Thank you. And sorry, Kavita. So before we start our meeting, we do need to vote for a committee chair and a new vice chair for the upcoming term. Because Kavita, this is your last meeting with us, so we have some
Only us this
changes.
time.
I know. So we have some changes, so we do have to vote for a chair. Um, so as we do this vote, if we can get our committees to come back on screen so that we can start our vote.
And Kavita here. Nania, can you confirm all the other members right now besides me, they all have like how many they're all here for another year, right? Before we
So
start nominating names for people who are
yes,
ending their terms.
yeah. So the only other committee members that would not be that are ending their term this month, 2024, is John McKay and Michael Borsellis. Those are
Okay.
the two that will not be moving forward in the term. But everyone else is here. So we have Gregory, Zoe, Laura, um, Kevin, Christy, I'm sorry, and Peter. And I'm looking at listening. I want to make sure that I'm listing everyone correctly. Um, I was able to get John and Michael's vote. Um, so the votes were as follow. John and Michael voted the same. They
No.
both voted for Peter to be chair, and they both voted for Laura to be vice chair. So just want to tell their votes before, as you guys are making your considerations and voting.
Okay, so it sounds like we have two names already in the ring before we start asking for votes. Laura and Peter's names have already been nominated. Any other names to be nominated from the committee? And then yeah, go ahead, Laura.
So I would vote for Peter for chair and Greg Hudson for vice chair.
Okay, thank you, Laura.
I'll just say I was going to vote for Laura for chair.
This is
all right.
Christy. Can I ask a clarifying question, Laura? Do you not want vice chair, or are you opposed to that?
I am fine with vice chair. We've got construction going on and we're in between kind of limbo, so it might be easier for me to be vice chair because I may have to miss at least one meeting next year. So just for logistics on my end.
Laura is self-sacrificing. Thank you. Go ahead.
I support Peter for chair.
Okay. Zoe.
Whoever wants to do it, I'm happy to support them. It's kind of weird that people don't nominate themselves first before we like decide for them, but if Peter wants to do it, that's great.
Greg, any thoughts?
Just that I guess I'm still in my first year, so it's a bit, I don't know. I think I still want to get my feet under me a little bit before considering a leadership role. But I think I'd go with Peter as chair and Laura as vice chair if they're comfortable with those roles.
All right. I support that as well, especially after I was going to nominate Laura for chair, but after what she shared, I am happy to also vote for Peter as chair and Laura as vice chair.
Thank you for the support.
So, Nanya, do we have everybody's votes then?
So can we make it unanimous, please?
Okay, so everybody who says aye to Peter for chair, Peter Barquette for chair, and Laura Bestie for vice chair, say aye.
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 Any opposed or alternative suggestions? Sounds unanimous to me.
It's unanimous to me too. Thank you, everyone.
Thank you. Congratulations, Peter.
Congratulations, Peter.
Thanks, I'm honored. I'll try to live up to it.
Fantastic. Anything else, Nanya, before we move on to our agenda?
That's it for me. Thank you.
Excellent. Thank you. All right, and with that, let's open up our PNT committee meeting. We convene with our DUR presenters. We have Wesley Lindsay starting us off with non-asthma biologics. Hello, Wesley.
Good morning or good afternoon, depending on where you're located. We're in the central time zone, so 1 p.m. here. So good morning or good afternoon to all. Is audio okay? Is everybody able to hear me clear?
Sounds great.
All right. And I will share screen to get the slideshow started. And are you seeing slides?
Yes, we are.
We are seeing the non-presenter version. There we go. Yep.
Perfect.
Okay. Very good. All right. Well, thank you very much. I'm excited to join you today. It's always a pleasure to be able to present the findings of our research projects. Apparently, though, Christmas has come early, so this committee has been good this year. You get to talk about biologic drugs for these non-asthma indications. And so excited to present this, and let's just dive into it. So for our research team, we didn't have any conflicts of interest to disclose for this particular project or any of the products that we'll talk about today. Just providing a brief overview of our presentation today. First, we'll talk just briefly about the background of these diseases and medications. We'll go through our PICOs, and so to define our populations, interventions, comparators, outcomes, and study types. We'll provide an overview of the key questions that were provided for this project to try to define the place and practice for some of these medications. We'll discuss our methods, so how we went about performing this particular review. Obviously, where you're probably most interested, we'll discuss our findings for the different medications that are part of this review, and then we'll provide our discussion, so our overall takeaway points. Because we're talking about inflammatory diseases and a number of different indications today, we wanted to provide just an abbreviation overview. I'm not going to go through all of these, but I will just kind of set the table a little bit. For chronic rhinosinusitis and rhinosinusitis with nasal polyps, I'm basically going to use those terms interchangeably. Almost all of the data that we talk about for this project are in participants and patients with nasal polyps. So essentially, when I say chronic rhinosinusitis, I'm talking about with nasal polyps. Also for EGPA, or eosinophilic granulomatosis with polyangiitis, I am going to take the easy way and say EGPA. I did make the joke when I presented this the first time that I was working on a song with eosinophilic granulomatosis with polyangiitis in the song, and I'm still working on that if we have any folks from the DURP team that heard that the first time. And so for some of the disease state measures that we have, we'll address those as we get into the individual indications for later today. A little bit of background and context. So obviously today we're talking about inflammatory conditions that are non-asthma in origin. And these can clearly have a significant impact on our patients' quality of life. We have those that have a dermatologic presentation like chronic spontaneous urticaria, and others that are a little more systemic, such as our eosinophilic granulomatosis. So they're associated with loss of smell, taste, and impaired sleep, as well as itching and reduced mental and emotional health. And the biologic drugs that we talk about today are going to be used as part of the process to try to influence inflammation and improve the symptoms associated with these diseases. So this particular report is actually an update. We performed a review on this in October and presented in October of 2021. So you'll see later on when we get to the findings, the way that we've structured this report is we provide a little bit of an emphasis on the new material, and then we go into, okay, what does the whole picture say for this indication, incorporating the new material into that stuff that was part of the previous presentation. And as they always say, the sequel is never as good as the original, but I'm hoping that this particular report is the Top Gun Maverick of DURP reports, that the sequel can at least hold its own with the original report. So for our populations, we're looking at both adults and children with one of our non-asthma conditions of interest. So again, chronic rhinosinusitis, chronic spontaneous urticaria, our EGPA, hypereosinophilic syndrome, and prurigo nodularis. And actually, prurigo nodularis is a new indication for this report. In the previous 2021 version, the first 4 were included and reviewed. And again, prurigo nodularis is brand new, so all the material associated with that indication is original to this report. The interventions that we're going to talk about today, we're going to talk about dupilumab, mepolizumab, and omalizumab. So those are the currently FDA-approved interventions. For pipeline agents that don't currently have an indication or labeled indication for these diseases we'll talk about today, we have our benralizumab, depemokimab, depemokimab. Oh, I knew I was going to get that wrong. Lirentelimab and tezepelumab. Oh, excuse me. So I missed the other side of the slide, the comparators. We're going to look at another listed intervention. And so we actually do have a head-to-head study as part of our evidence today. Any topical prescription therapies for those that have a dermatologic component, standard of care, and placebo. So the outcomes, we're not going to list them all on this slide. We'll address those individually as we get to each of these indications in turn. But obviously, we'll be looking at disease-specific outcomes, symptom control, quality of life, where that information is available, exacerbations, hospital admissions, mortality, and adverse events. The study designs that we're going to assess as part of this project, we're going to look at randomized controlled trials. And we're also going to look at studies that are for countries that are rated as very high on the United Nations Human Development Index. Questions that we want to address with this particular project. We obviously want to look at the effectiveness of these agents that we're going to be talking about today. We're going to assess the harms and adverse event profiles of these agents as well, and the characteristics of ongoing studies for the selected pipeline agents that have a PDUFA date within the next 12 months. So to discuss our methods for this particular project, we had three major sources of literature that we assessed. And so we had the typical DURP clinical evidence sources. So we looked at Ovid Medline, we looked at the Cochrane Library, DuckDuckGo, Google Scholar. For ongoing studies, we assess clinicaltrials.gov, Scan Medicine, and the FDA resources as well. And other sources such as review articles and bibliographies of studies to make sure that we didn't miss anything in those particular areas. So a little more detail on our methodology. So we searched our DURP clinical evidence sources from January of 2021 to August 5th of 2024 for all of those therapies that were previously discussed in the 2021 report. If it wasn't part of the 2021 report, so it was a newer agent or a new indication like prurigo nodularis, then we had no limitation on the back end up to August 5th of 2024. As noted, we examined the bibliographies or reference lists of systematic reviews. We performed risk of bias assessments for all of our included studies. We used the grade approach for the overall assessment of clinical outcomes. And then as noted, we searched those resources indicated there for ongoing studies. Risk of bias, typical for a DURP project, we evaluated studies as having either a low, moderate, or high risk of bias. And for our certainty of evidence, once again, following the typical DURP process, we use the grade system for the most appropriate clinical outcomes for each of these indications. And so you can see we have 4 levels for grade, so high, moderate, low, and very low. So let's dive into our findings. Here's our Prisma diagram to walk you through the flow of literature through our particular project. So I will just call your attention down to the bottom box that's highlighted in green. So you can see for this particular project, we had 10 new randomized controlled trials among the indications, as well as we found 35 new additional publications, most of those being secondary analyses or post hoc analyses of studies that were part of the original project. And we carried forward 20 RCTs that had 6 additional secondary publications from that original report. So some of that same information, but maybe packaged a little bit differently here. You can see we had 10 total new studies. Of those 10 total new randomized controlled trials, 6 had a low risk of bias, 3 had a moderate risk of bias, and 1 had a high risk of bias. Looking at the populations that were evaluated, 9 of these studies assessed adults only, and 1 evaluated adolescents and adults. And for the comparators, we had 9 of these were placebo-controlled, and 1 of these, which we'll get to, is actually a head-to-head study of our 2 agents. So how does this new information fit into the total overall assessment of evidence? So combining what we had in the previous project, we have a total now of 30 randomized controlled trials. So 30 studies with 41 additional secondary publications. For these 30 studies, 6 in total had a low risk of bias, 20 were assessed with a moderate risk of bias, and then 4 with a high risk of bias. Of our populations, 27 of these assessed only adults, and then the balance, 3 assessed adults and adolescents. And for comparators, 29 of these assessed placebo or usual care. And then again, we have our 1 head-to-head study, which we'll discuss today. So let's take each of our indications in turn. So we'll start with chronic rhinosinusitis, or CRS. So because each of these indications had their own assessment tools, we provided just an overview of some of the major assessment tools for each of these on the slide. This is probably one of my favorites because in this we have the nasal polyp score, the nasal congestion score, and the evupopular SNOT 20 and SNOT 22. Clearly, this is going to be one of my favorite slides because it's always exciting to be able to say things like SNOT 22 in a professional setting and it be acceptable. So some of the characteristics of our new studies, we actually had 4 that were part of this indication. So 3 of these looking at benralizumab and 1 of them looking at mepolizumab. You can see that, again, all of these are randomized controlled trials. You can see from the interventions and sample sizes that we have 1 benralizumab study, which was, a pretty good size with 413 participants. Unfortunately, the others are relatively small, and you can see the sample sizes there in the second and third rows. And then for mepolizumab, we have the 1 study with roughly 80 participants per treatment arm. Study durations, you can see there, both 6 months and 1 year. And you can see the risk of bias associated with each of these new studies. So where do these new studies fit into the whole picture then? So for benralizumab, we have 3 total randomized controlled trials in adults with a total of 493 participants. For dupilumab versus placebo, we have adults and adolescents with 3 total RCTs. Although we do have some relatively large sample sizes here with 2,686 total participants. Mepolizumab is assessed only in adults with 4 randomized controlled trials with 707 participants, and omalizumab in adults and adolescents with 3 RCTs with just under 300 total participants. So looking at each of these agents individually. So for benralizumab and chronic rhinosinusitis, one of the clinical assessments that was evaluated was improvement in that nasal polyp score. So we had 3 RCTs assess this outcome. The grade rating assigned to this particular outcome was actually low. And we saw some inconsistency within the studies that we saw significant improvement in one of the larger studies, but no change compared to placebo when actually looking at the 2 other studies. When looking at the SNOT 22 and the 3 RCTs amongst the 3 studies, we had this with a grade of moderate, and we actually saw no significant change in the SNOT 22 scores compared with placebo. And in time to nasal polyp surgery after starting therapy, 1 RCT assessed this particular outcome. We assessed it with a grade of moderate, but we actually saw no change in time to surgery compared with placebo. In adverse events of benralizumab, we had 3 RCTs. This we actually had a grade of high, and the adverse events were relatively mild, and there were actually no serious adverse events reported for this agent. Looking at dupilumab in chronic rhinosinusitis, this is an older outcome, improvement in FEV1. So no other studies or no other drugs assessed this particular outcome, as well as any of the newer medications, but it was common to dupilumab in some of the older studies. So looking at that FEV1, we had 3 RCTs assessing this outcome with a grade of moderate. And we did see that dupilumab did improve FEV1 from baseline compared to placebo. Looking at the change in the nasal polyp score, so again, that's a little bit of a newer assessment. We had 2 RCTs evaluating that outcome. We assessed this as having a grade of moderate, and that dupilumab actually did improve NPS compared with placebo. And looking at the change in the nasal congestion score, we had 1 RCT assessing this outcome, having a grade of moderate, and we did again see some improvement with dupilumab for this indication, or excuse me, for this outcome. Looking at improvement in the SNOT 22, we had 3 RCTs with a grade of moderate, and we did see that dupilumab was actually associated with an improvement in the SNOT 22 score compared with placebo. And then for adverse events, we had this with a grade of moderate, and that mild adverse events were common, but there were no differences between the 2 study groups. Looking at mepolizumab in chronic rhinosinusitis. So looking at improvement in that nasal polyp score, We did see with 4 RCTs, improvement compared with placebo, but we had a grade rating of low on this particular assessment. For improvement in the SNOT-22, we had a grade of moderate for this particular assessment, and we noted that SNOT-22 scores actually did improve compared to placebo. And for adverse events, we had this with a grade of moderate, and that there were mild adverse events were common, but no differences between mepolizumab and the placebo groups. So for omalizumab, I guess tomato, improvement in the nasal polyp score. With 2 RCTs, we had a grade of low on this particular outcome, and then we did see some improvement compared with placebo. Looking at the SNOT-22 score, we assessed this as having a grade of moderate, and we saw some improved SNOT-22 scores compared with placebo. And looking at the nasal congestion score, we had 1 RCT with a grade of moderate on this outcome, and we did see that omalizumab did improve the NCS compared with placebo. So that's chronic rhinosinusitis. Let's look at chronic spontaneous urticaria. So we have a number of different assessment tools looking at and assessing chronic spontaneous urticaria, none with a name as colorful as SNOT-22, so we're a little bit disappointed. We need to do better in this particular indication with our acronyms, but I'm sure somebody will come up with something. But just to give you an idea of the different assessment tools available for CSU. Looking at the new studies that were published for CSU, we had 1 looking at benralizumab, 1 looking at dupilumab, and 1 looking at omalizumab. So you can see with each of these, not huge studies, but in particular looking at the omalizumab study, only 5 participants per study group. So as you can imagine, not a lot of quality information we were able to pull from this particular study. You can see study durations as you move across the columns, 52 and 24 weeks. And 2 of the studies having a low risk of bias, but as you can see, the small study on the bottom having a high risk of bias. So then how do these new studies fit into the overall picture of literature on this particular indication? So you can see with the benralizumab, we have this 1 new randomized controlled trial. For dupilumab, we have 1 randomized controlled trial. And for omalizumab, we have a total of 9 randomized controlled trials with just over 1,500 total participants among these studies. And you can see on the right, the study durations anywhere from 20 to 60 weeks. So looking at these individual agents, so for benralizumab, and CSU, look at the improvement in this symptom score, the itch symptom score. 1 RCT with a grade of moderate. And actually for this one, we saw no change in this particular outcome compared with placebo. For improvement in the urticaria score, again, we saw no change compared with placebo. And the participants that had a UAS-7 score of less than 6, so those that had a stronger response to medication, once again, no change compared with placebo, all these with a grade of moderate. So benralizumab didn't really stand out for this particular indication either. So participants with a UAS-7 of 0, which indicates remission, no change compared with placebo, and improvement in a hive severity score over a week. Again, a grade of moderate on that with no change compared to placebo. And for our adverse events, we had a grade of moderate, but again, no notable differences compared with placebo. For dupilumab, looking at some of these same outcome assessment tools. So looking at improvement in the urticaria score, we assessed this as having a grade of moderate, and we did actually see dupilumab show some improvement compared with placebo. Looking at the itch severity score, we actually had this with a grade of low, because in the publication, there were sort of 2 study subgroups with a Cupid A and Cupid B, one of those being treatment naive and others having previously been treated. And so scores in the Cupid A study participants, there was no improvement. But in Cupid B, we actually did see some improvement in those. So a little bit of inconsistency there. And participants, again, with a UAS-7 score of less than 6, so that they had response. With a grade setting of moderate, or grade rating of moderate, sorry, we did see that dupilumab showed significant improvement compared to placebo. In participants with a UAS score of 0, so that would indicate that they had a full response. So we saw that dupilumab did show significant improvement with placebo compared again in that Cupid A study, so one of the subgroups, but not in the other. For improvement in the Hive severity score, had a grade of moderate, and dupilumab did show improvement compared to placebo in both of those study groups. And for the adverse events, we rated that as having a high grade or certainty of evidence, because adverse events were, again, relatively mild and no serious SAEs were reported. So omalizumab, which has the largest body of evidence for this particular indication. So improvement in that UAS, so that urticaria score. We had 8 total RCTs with a grade rating of high. And we did see that omalizumab actually did show significant and consistent improvement among those studies when compared with placebo. Looking at the itch severity score, we had 5 total RCTs assessing this outcome with a grade of moderate, and the omalizumab actually did show some significant improvement compared to placebo. And looking at the improvement in quality of life from baseline, we had 7 RCTs with a grade of moderate, and the omalizumab did show improvement compared to placebo. So that's chronic spontaneous urticaria. What about EGPA? So for this, we had one new study in this particular space, and this is actually our head-to-head study, which was foreshadowed before. So this looking at benralizumab and mepolizumab, and this is actually a non-inferiority study, unfortunately. It was a 52-week study that has a low risk of bias. So now looking at sort of the total literature for this indication, we have this head-to-head study just mentioned in adults with a total of 140 participants. And then we had one previous study with mepolizumab looking at adults in 136 participants. So looking just at benralizumab, so we had remission. We had this with that one RCT and a grade of moderate. And benralizumab was deemed to be non-inferior to mepolizumab. The same for relapse. We had a grade of moderate on this one, and benralizumab being non-inferior to mepolizumab. And for the adverse events, we had, again, just the same RCT with a grade of moderate, and there were no notable differences between the 2 treatment arms. So looking at our mepolizumab, for remission, we had this again, one RCT with a grade rating or certainty of evidence of low on this one. So mepolizumab did increase accrued time to remission compared with placebo. For relapse, we had a grade of low on this one, and that mepolizumab did delay time to relapse compared with placebo. And for our adverse events, a grade of moderate and no major differences between mepolizumab and placebo. So as we move down our indications, you can see we have a little bit less evidence for each of these. And we just took them in alphabetical order, but that was just by chance. So we actually had no new clinical trials in this particular indication. And so all we have are 2 studies that we pulled forward from the original 2021 report for mepolizumab versus placebo. We can see that this is actually studied in both adults and adolescents with a total of 2 RCTs, just under 200 participants for the studies combined, and 32 to 36 weeks for study durations. So looking at an outcome of the reduction in oral corticosteroid usage or dosage, we had one RCT with a grade of moderate. And so mepolizumab did reduce the use of prednisone during treatment when compared with placebo. At time to first flare, we assessed this with a grade of moderate, and we saw that the occurrence of flares with mepolizumab was 50% lower than with placebo. Now, I know some of you are thinking, well, that doesn't really answer the question. If you say time to first flare, how much longer was the time to first flare? And actually, they didn't say within the study. They only said that the occurrence of flares was lower, was 50% lower, but they never actually provided any sort of time window that directly addressed the outcome. So there's that. And then for adverse events, we had the 2 RCTs, this with a grade of low, and that we saw adverse events occurrence was similar between mepolizumab and placebo. I will say full disclosure here on slide 45, when I originally presented this, we found a typo on this very last line. And so I actually did update it and change it for the presentation today. So all of you type A's out there will understand that when I saw that, I just couldn't live with it. And so if you'd like this updated version, we'll be happy to send you that after the meeting today. So looking at prurigo nodularis, again, this is a new indication for this particular report. And so we had one randomized controlled trial to report looking at dupilumab, a study duration of 24 weeks, and this having a low risk of bias. Once again, a number of different assessment tools available to assess the different components of prurigo nodularis. Give you just a moment to kind of look through those. So looking at dupilumab and its impact, so the improvement in the worst itch score. So the way this one was kind of structured is a little different. So you can see here we had 2 RCTs, whereas here we said, oh, there was only one. So the way it was kind of structured, it was actually one publication, but it had 2 separate clinical trials associated with the PRIME and the PRIME 2. And the difference between the two, honestly, was when they assessed the primary outcome. But they had 2 completely different NCTs. They were 2 totally different studies. They didn't pool the results. So technically, they were 2 trials in one publication. So that's maybe why the numbers, if you're, again, the type A, and you're like, wait a minute, these numbers don't work. I'm a type A too, so I made sure that the numbers worked. So looking again at that worst itch with a grade of moderate, we did see that dupilumab improved this particular outcome compared with placebo. Same with the improvement in skin pain with a grade of moderate, and we saw that dupilumab did improve this outcome. Improvement in sleep, we could all use a little bit of that, but we did see dupilumab improve the sleep score compared with placebo. The Dermatologic Life Quality Index, we saw again dupilumab improving that outcome with a grade of moderate. So looking at the investigators global assessment, with a grade of moderate, dupilumab improved this particular outcome. And adverse events, we had a grade of moderate. And once again, dupilumab and placebo had similar adverse event profiles within the studies. So what about our ongoing studies in this particular therapeutic space? So looking at chronic rhinosinusitis, you can see that we have a number of different studies here. 2 looking at dupilumab, 3 actually looking at mepolizumab, and 1 assessing tezepelumab. You can see the estimated enrollment numbers for each of these studies as you move left to right. The outcomes, and of course the ever popular SNOT-22 being a common and popular outcome assessed between the studies. And those estimated completion dates anywhere from August of 2024 out to March of 2026. So mark your calendars. For chronic spontaneous urticaria, we have 2 ongoing studies, one with omalizumab and one with tezepelumab. And again, as moving left to right, you can see the estimated enrollment and outcome measures being assessed, as well as the estimated completion dates. For EGPA, we have 4 ongoing studies, one with each of the agents listed here in the dupilumab, actually being a head-to-head study with mepolizumab, with also a placebo treatment arm in there. Dupilumab versus placebo, mepolizumab versus placebo versus systemic immunosuppressants, and the tezepelumab, again, looking at the estimated enrollment, for the outcomes assessed in each of these studies and estimated dates of completion. Hypereosinophilic syndrome, there are none. I know some of you probably see a PowerPoint slide. For others, you see a work of art. I actually thought about printing this out and putting on my refrigerator at home. So this slide is beautiful in its simplicity. And looking at prurigo nodularis, we have one ongoing studies with dipemokimab, one ongoing study with dipemokimab with 120 participants, and you can see the outcomes and estimated completion there. All right, so everybody's favorite part, the end. So most of these interventions were associated with some level of improvement in their respective outcomes, with one notable exception there, benralizumab. It really just didn't demonstrate much in the way of improvement in chronic rhinosinusitis and in chronic spontaneous urticaria. And the one head-to-head study we did have, benralizumab was non-inferior to mepolizumab in EGPA. Obviously, we have a lack of head-to-head studies. Of the 30 studies we have available, only one is actually a head-to-head. So obviously, placing therapy can be a little bit of a challenge. The grade ratings were generally moderate, as we had, in most cases, a relatively small number of studies in relatively small patient participant pools. We typically had grade ratings that were somewhat higher for the adverse event outcomes, and that's generally because they adhere to or aligned with what you would see in the typical monograph profile, as well as generally similar to placebo. Very few serious adverse events were reported throughout the studies. And some common limitations, as noted, small studies, the variety of outcome tools used, and then a lack of head-to-head evidence. So with that, I'm happy to open the floor and take any questions that you may have.
I see the committee coming on. Any questions from the committee for Wesley? Okay. And Nanya, I don't see any stakeholders listed.
And I do not see anyone's hands raised.
Okay, great. So if no questions, can we look at the motion, please?
Yep.
Would you like me to stop share at this point?
Yeah, that'd be great. Thank you.
Okay.
Okay, so I see the dupilumab that we reviewed today that's been added on. Nanya, am I reading that right? To the previous motions?
Yes.
Is in the atopic dermatitis class on the Washington PDL. So because it was originally in that class, but also has studies in the biologics for non-asthma indications, it's part of this review. But when we do our cost analysis and updates, it does impact that atopic dermatitis class. So the bold, the benralizumab, is what's new in this report. So even though it is approved and on the PDL for asthma indications, it's new for the non-asthma indications. So those studies that Wes was just walking through and talking about in the conclusions where, they were inconsistent or lacked efficacy, those are kind of the new what's being new in this update to this drug class. So just know that once you make a decision on benralizumab, for the non-asthma indications, knowing that we're doing this cost analysis for all of its covered conditions, so we're also going to be looking at it for asthma as well.
Got it. That's helpful, Ryan. Thank you. And then as I'm reading through the motion here, I am wondering whether the second sentence where it lists the drugs and then says can be subject to therapeutic interchange. Do we need to include benralizumab on that list as well, or is there a separate rule that applies to benralizumab?
So this is Ryan, and the reason why benralizumab was added in the first part of the motion is because it is, an FDA approved, in these other indications, and those were the studies that you saw. But I didn't add it to the second half because I didn't know if you felt that the level of evidence and the outcomes in the studies that were presented today warranted it to be in the same level of therapeutic interchange, or if you wanted to potentially treat it differently based off of, what you saw today for those non-asthma indications. And so really it's up for the committee to debate and decide what you feel we should do with benralizumab in respect to these indications, these non-asthma indications.
Okay. What thoughts does the committee have?
So this is Laura Bestie. So my question is the benralizumab doesn't look like it is FDA approved for all the indications that we went over, or is it? I'm trying to look it up right now.
So this is Ryan. I believe some are still in the pipeline that are being reviewed by the FDA. Wes, is that correct? Are they in review?
I'm working off the top of my head, but I think it is approved for the asthma indications, but for the non-asthma indications today, I don't believe that it has an approved usage there.
It looks like it might be approved for eosinophilic granulomatosis with polyangiitis.
That might be true. So I was working off memory there.
Pulling up the PI. Yeah, eosinophilic. Yep. So EGPA would be the only FDA approved indication that is applicable to that first sentence, right? Because it's for their FDA approved indications excluding asthma. So it would just be the EGPA.
Which, if I believe this is Laura, is correct that it was efficacious for that indication, but not for the urticaria, correct?
Yes, I believe that was in this is Ryan. I believe that was correct based off of what Wes had presented in that conclusion slide, that there lacked efficacy.
So if that is true, then wouldn't we be okay saying that it could be subject to therapeutic interchange for the FDA approved indications because it was efficacious for that indication that is FDA approved for?
Okay, so this is
As
Ryan.
I'm,
So
as I'm
do you want
looking
to add?
here, sorry.
Oh, go ahead, Wes.
Well, as I'm looking here, the only thing that I see it approved for is the eosinophilic asthma. So it's not the eosinophilic granulomatosis. That's actually a different, I think that's a slightly different indication. So for eosinophilic asthma, it is approved, but for the other non-asthma inflammatory conditions, I don't think that benralizumab does have an FDA approval.
So then we shouldn't be adding it at all to this statement then, right? Because it's not approved for any non-asthma conditions.
So this is Ryan, and I pulled up the prescribing information from their website. It does list treatment of adult patients with EGPA, in addition to add-on maintenance treatment of adults and pediatrics with severe asthma and with an eosinophilic phenotype.
Yeah, that's correct. I can put the
Okay, that
date of
makes
the
sense.
FDA approval into the chat.
That makes more sense that that's why it was added then. I agree with Laura then in theory that like if we're okay with all of these being substituted for the things they are FDA approved for, then there's no reason not to also have benralizumab substitutable in for that one thing, which the language does state. I guess I just don't know enough to know if it's appropriate at all to have these be substituted, especially if it's the kind of thing where a patient like tried one and failed, and then they need to try another one, and then they need to try another one, like the way other rheumatologic drugs are.
Kavita here, and as I understand, maybe Ryan, you can speak to this as well. Just with these monoclonal antibodies in general, is there that much therapeutic interchange anyway?
So this is Ryan, and typically there isn't because these are typically on PA for the preferred options for Apple Health or for UMP or other applicable health plans, and so we don't necessarily see a lot, but the ability to have that in place, would be preferred. So that way, the pharmacist, at that time can make that substitution and not necessarily have to deal with the administrative burden of going through a PA for a preferred product. So it sounds like you would want to include the benralizumab in that second sentence and allow it to be eligible for therapeutic interchange for that one indication.
For that FDA indication, yeah. Peter, what are you thinking?
Oh, I was just gonna ask, if this is only for pharmacy fill, or if we do like therapeutic interchange for in-office administrations too.
Hmm.
Is this getting used for both? Because I think the new thing a couple of years ago was doing omalizumab through the pharmacy and then having people inject at home. And and typically, I think our the preferred drug list and everything applies to the pharmacy fills. But is this going to get applied at all to in-office administration?
Ryan, and that's a really good question. Um, I think the way that TIP was designed, and this was, originally effective back in 2007, is that it was really just for the pharmacy benefit. But I don't know if there is any way that it would apply to a physician administered drug, like if it was billed on a medical claim. So let me just do a little bit of research and see. But for the most part, we've only really ever considered this as a pharmacy dispensing type of allowance.
So on the basis of that discussion, Kavita here, on the basis of that discussion, I can see Nanya added the benralizumab in the second sentence as well, because it only has that one FDA approved indication for the EGPA. So how does the committee feel about that? Do we like it as it's written to move forward with the motion or any other edits? Smaller committee today, so I can almost see all of you on one screen. Okay, so I'm seeing nodding heads. Okay, so then I'll
So, go ahead.
go ahead. No, go ahead, Laura.
This is Laura Bestie. I will make a motion to approve biologics for non-asthma conditions after considering the evidence and safety and efficacy in special populations for the treatment of their FDA-approved indications, including asthma. I move that benralizumab, dupilumab, mopolizumab, omalizumab are safe and efficacious for the treatment of their approved indications. Benralizumab, dupilumab, mepolizumab, omalizumab can be subject to therapeutic interchange in the Washington preferred drug list for their FDA approved indications, excluding asthma.
Christy Wyland.
All in favor, please say aye.
Aye.
With that, the motion carries. I think, Laura, you have the track record for pronouncing the most number of drug names accurately without stumbling over
A
them.
little bit of a glitch there, but
Excellent.
This is Ryan. So to answer Peter's question, it likely doesn't apply on the physician administered side because the way that therapeutic interchange works is that if a participating prescriber writes a medication for a non-preferred drug and there is therapeutic interchange in the class, the pharmacist can then substitute for the preferred one without needing to notify the prescriber that they had substituted to a drug within that therapeutic interchange. So in the case of a physician-administered drug, that physician is there, and so it's not necessarily happening. It's likely that the physician would just redo the prescription for that preferred drug. So I don't really see tip happening. I see something maybe similar happening in which they're reselecting a preferred drug, but it wouldn't technically be therapeutic interchange like we have through this program.
Thanks.
Excellent. Thank you for that, Ryan. All right, and then on the basis of our agenda, the next item is our ADHD medications, and for that we go to Shannon Robolina.
I am just pulling up my slides. Can you guys hear me okay?
Yes, we can, Shannon.
Great.
Shannon gets the drug classes that are easy to pronounce. I always get the biologics or the gene therapies that are the etranacogene, diflucanogenated, all of those. So you lucked out on this one, Shannon.
On this one, but I get to do the pipeline report at the DUR conference. So that's full of weird stuff. Okay. Hopefully you're seeing the correct screen, just the slide deck and not my notes.
Yes, we are.
Perfect. Okay. Well, thanks for staying on today. I'll walk you through. This is just a surveillance report on pharmacological therapies for ADHD. As Wes noted, this is our standard notices and disclosures, and I have nothing to disclose, and neither do any of my colleagues at the center who assisted with this surveillance report. As Wes's presentation, we'll do similar background PICOs, key questions, methods, findings, and summary, though we do not do detailed findings for these surveillance topics. So just a little bit of background and context. Currently, ADHD affects around 11% of U.S. children and adolescents, and around 2/3 of those are using medications, though this really ranges across states from 38% to 80%, and around 4.5% to 5% of U.S. adults have been diagnosed with ADHD, and about 3/4 are receiving some type of treatment. So that can be psychotherapy, medication, etc. Of those being medicated, approximately 80% are using stimulant medications. And as we know, U.S. adults or adults in general are being diagnosed more often these days with ADHD. So when the DSM-5 came out, they did change the criteria for ADHD. Now the symptoms need to be present by age 12, regardless of when they were diagnosed. They need to be present in 2 or more settings. So this could be in the workplace, school, social situations, etc. And they need to interfere with functioning in school, work, or social settings and not be better explained by another mental health condition. There are 3 symptomatic presentations of ADHD, though in the ADHD world, this is a little bit controversial, but they are still used. So there's the predominantly inattentive, predominantly hyperactive, and then the combination of the 2. Psychiatric comorbidities are incredibly common with learning disorders, oppositional defiant disorders, and anxiety in children, as well as depression, anxiety, and substance use being commonly seen in adults. So there are the pharmacological treatments. There's the stimulants and non-stimulants, for example, as well as a few that are other drugs that are used off-label. There are currently 31 treatments approved by the FDA for ADHD. There's also the behavioral interventions, setting-specific interventions, so maybe like a workplace accommodation, and some individuals get a combination of these therapies. In terms of what ADHD looks like in Medicaid, The rate of children with ADHD in Medicaid is almost 3 times that of the national average across private insurers. So the private insurers, it's around 5%, and in Medicaid, it's 13%. For children that are identified as African American, they're less likely to receive follow-up care and more likely to discontinue and disengage with their care. And individuals who are white, male, and living in a two-parent household are more likely to be assessed and treated, especially within Medicaid. For Medicaid enrolled adults, this is similar to the African American population, African American children population, with males and those living rurally much less likely to initiate and continue treatment. Medication initiation in adults is hugely varied across the US, with a low of 8% in New Jersey and around 50% in Tennessee. So just a brief history of this topic. So back in 2021, we did a full systematic review that included 70 studies. You can see the breakdown of those studies on the screen there. They were almost all RCTs. There's one post hoc analysis of some RCTs. Back in October of last year, we did our first surveillance report. And this is our second surveillance report. And if you're familiar with these DUR surveillance reports, usually we only present you the information that we identified for that current surveillance report. But because the evidence for this topic is kind of weird, we're going to present everything that we've identified since that 2021 systematic review. So we're interested in any population of with ADHD of any presentation. We're looking at the pharmacological treatment. So we're looking for comparators of intervention of other pharmacological interventions. Sorry, I forgot how to speak today. We're also looking at standard of care or placebo only for treatments that have been approved since January of 2015. And for studies that enrolled individuals aged 18 years or older, so for those adult populations. We're looking at RCTs only. And just to note that we do exclude comparisons of brand names with the generic equivalent, comparisons. We have excluded comparisons of different doses of the same medication, and explicitly included multimodal treatment. And just to highlight again that for adult populations, we're looking at really any comparator just because that evidence is so limited or has been so limited up until now. I'm not going to read all of these names. Sorry, Wes. So this is one of 4 slides that I'll flip through in a moment here of all of the FDA approved treatments. Those that are highlighted in the kind of peachy colored rows, those are new since the 2021 review. So you can see that we have 3 new stimulant medications on this slide. But I also want to highlight these, and I'll discuss these more later, that there have been 4 brand names that have been withdrawn from the market. So again, some more stimulants. And we do have 1 new non-stimulant that was approved earlier this year, as well as 1 that was removed from the market. So in terms of what outcomes we're interested in, so we're looking at efficacy and effectiveness, a symptom response, functional capacity, quality of life, time to onset of effectiveness and duration of effectiveness. For harms, that we're looking at how well the treatments are tolerated. Are there any serious and long-term adverse events, and misuse and diversion? We have 4 key questions here: the effectiveness of these treatments, harms of these treatments, differences between the subgroups, and ongoing studies. Our methods for these surveillance topics is that we look at the registered trials. So we look at a number of registered trial databases to identify trial numbers and trial names. We then searched for those trial numbers and trial names in Ovid Medline, Google Scholar, and we also look at the FDA website and IPD analytics to identify any treatments and trials that we may have missed. So the search for this surveillance document covers the period of July 1st, 2021 through the end of July this year. So what have we found? So we'll start with the FDA actions and pipeline therapies. So as I already highlighted, there have been 4 new treatments approved since 2021. 3 of those are stimulants. They are all approved for treatment in individuals age 6 and over. And you can see the dates of when these were approved. And I highlighted these as well, that there have been 4 brand name drugs that have been removed from the market. Some of these were newer. And just to highlight that things like Adzenys ER and amphetamine was removed, but they still have the Adzenys XR ODT, an oral disintegrating tablet that still remains on the market. Similarly with Evekio ODT, the ODT version has been removed, but the regular old oral tablet remains available. So Evekio did have a new indication back in September of 2022. Previously, it had been approved for ages 3 and up, but they've removed that indication for those children aged 3 to 5 years old and remains available for use in patients 6 to 17 years old. Qelbree, viloxazine, was approved in 2022, and now they've expanded the use beyond the age of 17, so for adults and children above the age of 6. There are a number of pipeline treatments in the works. There is one that's been on the top of this list with a pending PDUFA date for some time. That is the AR19. And then there are a number of them in phase 3 trials. I did have a peek yesterday, and these are all still in this phase 3 or PDUFA pending, no further date on that PDUFA. So new box warnings. In October of 2023, the FDA added a new box warning on all ADHD stimulant medications, noting that they have a high potential for abuse and misuse. Viloxazine also received a boxed warning to monitor patients for emergence or worsening of suicidal thoughts and behaviors. There's a lot more detail about these. Got some on the next slide about other harms, but within the actual surveillance report, there's more detail about these boxed warnings. So there were also a lot of new harms added to ADHD stimulant medications. Some of them were new to the specific medication or expanded. For ease, I've just included them all here. So there were new harms around acute angle closure glaucoma, increased blood pressure and heart rate, increased intraocular pressure in glaucoma, increased risk of serotonin syndrome only for the Dianavil XR drug, long-term suppression of growth in pediatric patients, motor and verbal tics and worsening of Tourette syndrome, peripheral vasculopathy, including Raynaud's phenomenon, and that's for those newer amphetamine medications only, psychiatric adverse events, and risk to patients with serious cardiac disease. In terms of what we've identified in the published studies and ongoing studies, so since 2021, we've identified 13 new RCTs across 17 publications. We have one that is comparing a stimulant with a non-stimulant, one that's comparing a stimulant with mindfulness, one comparing a stimulant with placebo, not one, 5 in comparing stimulant with placebo in the adult populations, 2 for newer stimulants compared with placebo, 3 for the non-stimulants versus placebo, and 1 non-stimulant compared with CBT. And you can see what the total numbers look like. Some of them are really short in terms of duration, 1 week up to 52 weeks. So we'll look at these a little bit closer in the next slides. So of the new RCTs in the adult population, there was actually only one head-to-head RCT, and that's comparing atomoxetine to methamphetamine. And this was in a population of adults with major depressive disorder. We had a number of stimulants compared with placebo in this population. You can see that there are 5 of them here with lisdexamfetamine, methamphetamine, amphetamines, and other methamphetamine salts, and mixed amphetamine salts and methamphetamine. Oh my goodness, just lost the ability to speak. Methylphenidates. So you can see again that these are in adult populations. On the younger side, they range from around 20 to the mid 30s, and really different study sizes. We've got one that's down here, only 33 participants, up to 433 here. And just to note that this one also ran for a year and then ran for another 78 weeks with follow-up. So we also had 3 new RCTs in adults comparing non-stimulants. So these are all comparing those non-stimulants with placebo. Again, these are relatively short, 6 weeks to up to 12 weeks. 2 of these have quite large populations. And we have one that has a little bit older adult population, and these individuals all had PTSD. In terms of new RCTs for children, we had one head-to-head study, and this compared atomoxetine with atomoxetine and CBT or CBT alone in young children aged 8.5 was the mean. And this was the longest of these studies of 16 weeks. In terms of the other treatments, we have 3 comparing newer stimulants with placebo. I misspoke. There are 2 comparing newer treatments with placebo and 1 comparing a newer treatment with mindfulness. In terms of ongoing head-to-head studies, we found 3 of these. Only one of them was in adults comparing that stimulant to a non-stimulant. It's a larger study in adults with a history of psychosis or bipolar, and that's due to complete next year. In children, we had 2 new ongoing head-to-head RCTs, one comparing a stimulant with a non-stimulant or clonidine in children and adolescents with comorbid autism. That's due to complete in March of 2027. And lastly, one comparing a non-stimulant with another non-stimulant or placebo in children and adolescents due to complete in June of 2027. For placebo-controlled studies, we found 7 of these. We had 2 in adults comparing a stimulant to placebo. One requires at least half of the participants to have a diagnosed anxiety disorder. These are both relatively small studies, as you can see. Children, placebo-controlled style studies, we have 5 of those. 4 compare a stimulant to a placebo, and one of those is enrolling children with Down syndrome. We also have one comparing the non-stimulant viloxazine in younger children aged 4 to 5. So in summary, what have we found? We have 4 new drugs or formulations. 3 of these are stimulants and 1 is a non-stimulant. 2 new indications. Viloxazine is now available for use in adults, and Nevecchio has removed the use in young children ages 3 to 5. 4 new brand name treatments are no longer available. We have 8 pipeline therapies in phase 3 trials, with one of those having a pending PDUFA date, though no date has been given. We have 2 new box warnings All stimulant medications have the box warning about a high potential for abuse or misuse. The non-stimulant fluoxetine has a box warning for new or worsening suicidal thoughts and behaviors, and 9 new harms across the stimulant treatments. I'll not read these again to you, but they're all listed here. We also have 13 new RCTs since 2021. 3 of those are head-to-head, 1 in adults, 2 in children, 5 comparing a stimulant to placebo. All of these are in adults, and 5 comparing a non-stimulant with placebo, and 3 in adults and 2 in children. We also have 10 ongoing RCTs. 3 of those are head-to-head, 1 in adults and 2 in children, and the remainder are placebo-controlled studies, 2 in adults, comparing the stimulant with a placebo, and 4 in children, and 1 comparing a non-stimulant with placebo in children. So that is that. I'm happy to take any questions and apologize for my inability to speak today.
You did great, Shannon. All these drugs are tongue twisters. All right, Nanya, do we have any? Oh, actually, before I ask, any questions from the committee members for Shannon? Okay, and if not, Nanya, do we have any stakeholders?
Nope, I don't see any hands raised.
Okay. All right, then let's have a look at the motion.
Give me a quick second pulling it up. There we go.
I don't know if Ryan or Nanya knows why. I don't think I've seen that sentence in there about no single stimulant medication is associated with fewer adverse events in special populations. Is there a history to why that sentence was included in the motion?
Hi, this is Ryan. I don't recall that specific sentence and the history behind it. I just know that that was at one point a question about the stimulant medications, and it had been carried forward in every review since then. So I could do some digging, but I probably won't get an answer, today at this meeting on the history of that sentence.
Interesting. Thank you, Ryan. What does the committee think about that and also the rest of the motion?
Well, I don't know that we need that sentence. I think it's kind of implied with the therapeutic interchange
Right.
statement.
Yeah, this is Greg. I think it does serve to be a little, I don't know, confusing upon initially reading it. My initial thought is I'm wondering if we're trying to pull out cardiac patients, but again, just the fact that I'm sort of guess or I think it does serve to overcomplicate a little bit.
How does the committee, the only reason I bring that up is sometimes it can be, the motion is just for coverage in my mind, and it's not really any kind of clinical guidance. And so it feels weird to have any kind of clinical guidance included in the motion itself. And so just wanted to be cautious about that. Or I don't know if I'm overthinking it.
I don't think we need that sentence either.
No.
I would be fine with getting rid of it.
It's redundant because you've already said they're safe and efficacious.
Yeah, there you go.
Yeah. And there's
Cool, good.
Yeah. I mean, I was gonna say, into my experience, these statements don't include anything regarding like black box warnings or anything like that. So that, yeah, I just would agree that that statement feels superfluous.
Okay, good.
And
How about
this is Ryan. I would just say that, yeah, I think at the time, there was someone on the P&T committee who was interested in whether there were, and so I think given that there were none, they wanted to just kind of memorialize that. But to your point, if you're already saying they're safe and efficacious, it does create a redundancy. So I think it would be okay, to remove that.
other
And then-
comments? Yeah, go ahead.
Ryan, question. So the bit about therapeutic interchange, so like not allowing therapeutic interchange, is that because this is a protected drug class?
So this is Ryan, and yes, I think one of the reasons why this was a protected drug class, and why there is no therapeutic interchange is because the committee members, felt that they didn't want to be forcing people to switch between different ingredients if they were already stable on a treatment regimen.
This is Laura. So I would agree with not substituting as well, based on so many of them have a specific release mechanism, and a lot of people get the one that fits their schedule, especially kids with school. They have a release in the morning and then a release later in the afternoon. So they're not really efficacious, the similar release on any of them.
Yeah, it could be.
And I think there are enough agents to choose from. I don't think we need to have an interchange statement there. There's yeah. As long as we have a long and short acting stimulant of both methylphenidate and amphetamine based, then I think we should be pretty reasonably covered. Okay.
Go ahead, Luke.
Yeah, this is Luke. I also just wanted to say that these are primarily controlled substances, so I'm not sure it's necessarily legal to, engage in the therapeutic interchange program.
Oh, interesting. So if I heard you correctly, by
That's
virtue of being controlled meds, they are excluded from the tip anyway?
Yeah, that's my speculation. There a lot of them are C2 substances, so they're very highly regulated. And I would imagine from a pharmacist's perspective, they would need like hard copy scripts for these meds.
Got it. Yeah. Kavita here, I would also, I guess, I would agree with Laura in that I've seen that in my patients too, that even though I might have two patients both on long-acting formulations, but one will do much better on an amphetamine salt versus a methylphenidate salt. So I think I would support leaving the language as is. And plus, it sounds like it may not really be an issue since they are C2 substances. Other comments about the motion? Thank you for scrolling, Nanya.
This is Christy. Not that it's as issue as it used to be, but I don't think I understand a complete role of how does this take into consideration all the shortages that people are struggling with? Is there any, I suspect there's no role for that in here, but I just didn't know how that is figured out. Anyone, maybe
So
right.
yeah, so this is Ryan. So again, as the P&T committee, you're really just looking at the safety and efficacy of the studies and determining how the states, should structure our preferred drug lists and our pharmacy benefits. The DUR board side, which you'll be getting into a little later today, is where you'll have a little bit more, effect on the Apple Health programs. But even then, because these shortages and these other challenges are, kind of much more immediate than, how we meet as the DUR board, it's a little bit harder for you to, have a direct say in that. I think what you can do is just, give us the direction of, please make sure that you're doing what you can to, um, address, any shortages for, preferred products and, help make sure that patients are staying stable, on their medication regimens. But again, there's really not a lot of avenue that you have either as PNT or DUR.
Thank you. That helps clarify. That was what I was thinking.
And this is Greg, just to illustrate that, maybe Christy, I can think of examples where my patients, I send a prescription, my patients, or the pharmacy maybe out of like methylphenidate ER, they call me back and say, we don't have ER, but we have IR available. Would you like to substitute? And so again, kind of confirming what Luke is saying, that the pharmacy isn't able to, interchange and, in that circumstance, but, we do our best to work with the shortages.
Yeah, thank you for that. Several of my clinic patients are struggling to find product that will be covered because of the shortage.
So this is Laura. Continuing to read down, we state that clonidine and guanfacine are safe and efficacious, but we don't speak to the other meds. Is that intentional?
And I think what happened was is that we had previously reiterated the prior motions without adding in the other names of the non-stimulants. Again, that would be something that I would need to go back and look at prior meeting discussions, looking at their minutes. And so I don't know for sure, but I think that's one of the reasons why the other medications like the atomoxetine, aren't mentioned there.
We would want like the last two paragraphs to match though, right? So we would want either both of them to call out the names or neither of them to call out the names. So for both the non-alpha agonist and the alpha agonist groups.
Yeah, I think I would suggest that the second to last paragraph in the second sentence, we add the atomoxetine and viloxazine in there. I move that atomoxetine and viloxazine are safe and efficacious in at
Yeah.
least one non-stimulant, blah, blah, blah.
Yeah.
Yeah.
This is Laura. So could we just change it to I move that and then cross out the alpha agonist and then just list all four?
I think, the sentence or the paragraph above, says that I move that at least one non-stimulant that is not an alpha agonist. So between the atomoxetine and the vilaraxine, versus the alpha agonist paragraph, which is just the clonidine and guanfacine.
Got it.
So I think, you'll also want to take a look at the paragraph above and make sure that those two paragraphs are what you would want in terms of the motion.
I think what you're doing now makes sense.
Yeah, I think it's curious. You can tell the previous committee had also done some editing because it says in the second to last paragraph, I move that at least one non-stimulant that is not an alpha agonist that is safe and efficacious for ADHD should be included on the PDL. But Nanya, if you scroll up a bit more, please. I think they talk about all of the drugs as being safe and efficacious. Yeah, so it's a bit convoluted, isn't it?
Right. I think that's because the previous P&T committees felt that only one of the atomoxetine and the viloxazine could be preferred, but they wanted to have the clonidine and guanfacine, I think. And I think that's, how they structured it and how the Washington PDL is currently designed.
Okay, so it would be more just by the drug classes. They have two statements, one for the stimulants, one for the non-stimulants, and stating that they're safe and efficacious.
That is correct.
I mean, it's more verbose, but I think it is trying to cover everything as accurately as possible. So I'm fine, but I am open to comments about any edits if you would like to make it more succinct.
This is Laura. Should the second paragraph be after the third paragraph? Would that make more sense? Because you're speaking to these are safe and efficacious, and then if your last paragraph then would be that you move that at least one non-stimulant.
Let me see them both together. Yeah, so I think the way that this class was originally presented is that the alpha agonists were separate from the other non-stimulants, and that's why they were two separate paragraphs. And so I think if you want to have all of the non-stimulants together in one paragraph, you could delete the one above, and then at the bottom of the second paragraph, you can say that instead of, both, because now it's a list of four, you can say that, the alpha agonists must be included as preferred drugs on the Washington preferred drug list. And that, I think, is how you can reduce the size of this motion into something that's a little bit more stimulants and non-stimulants.
So this is Laura again. What about just cutting the second paragraph and adding on the bottom of the current third paragraph? I move that at least one alpha agonist and one non-stimulant. Wait, I move that one alpha agonist and one non-alpha agonist, because don't we want one of each to be on the preferred list?
So this is Ryan. So the prior P&T motion was that both alpha agonists and one of the non-stimulant non-alpha agonists. So it would be three of the four, with two of
Got
them
it.
being the clonidine and guanfacine. So that is if you want to keep the spirit of the old motion, is that, I think we have atomoxetine, clonidine, and guanfacine as the current preferreds.
Go ahead, Peter.
I was just going to say, we could probably take, because the first sentence of each of these three paragraphs starts off the exact same way. We could have one statement of safety and efficacy and just list off every single drug. And then we could have the requirements for what needs to be on the formulary and just, and so then that would be kind of a methylphenidate product of long and short acting, amphetamine-based product, long and short acting, two alpha agonists, and one non-stimulant, non-alpha agonist. I think that's probably the way to like reduce the verbiage the most. It would just be one statement of safety and efficacy, list all the drugs, and then have their requirements for the preferred drug list. That'd be my suggestion.
How do we feel, committee? I think we have a bit of analysis paralysis. Okay, so let's start wordsmithing a bit if we are not okay with the way it stands right now. Sounds like Laura and Peter, you each had some ideas about rephrasing it. Do you want to start helping Nanya put that together?
So we
Yeah,
can ask the rest of the committee. So one way would to do what Peter was suggesting, add it all as one, or we leave it as two separate your amphetamine method, your stimulant classes and the non-stimulant classes, but just make it into two paragraphs, one for each of the two separate classes.
that makes sense. Kind of figure out a direction before we get competing and verbiage down. Why don't we vote on Laura's idea first? Who wants to have two separate paragraphs, one for the stimulant type medications and one for non-stimulant?
Christy, I think the two paragraphs, dividing them out still makes sense to me, but almost completely eliminating that second paragraph, I think, as Laura was kind of saying, but just adding into that third a sentence or two.
Sounds good.
Yeah, this is Greg. I'd agree separating the stimulants and non-stimulants makes sense and simplifying it a bit. Yeah.
Okay. Well, let's go forward with some wordsmithing on that then.
So yeah, exactly. So that portion we include in the paragraph.
So then in the third paragraph, we're going to have our first part of it being safe and efficacious. And then we could end with, what about, I move that both alpha agonists and at least one non-alpha agonist that is safe and efficacious be included on the preferred drug list? How does that sound?
And eliminating that second paragraph. I agree.
Correct.
Sounds good to me.
Sorry, say that again.
Okay, so where we're starting, I move that both alpha agonists, and do we have to spell them out or can we just say both since
I think that's adequate, both out.
adequate? Okay, so
They're gonna
I move
refer
that
to
both
the
alpha agonists wait a minute. After considering especially I can move that both. Okay, both alpha agonists and at least one non-alpha agonist be included as a preferred drug on the Washington State preferred drug list.
Okay, sorry. At least.
Right. So then we have to move that one part, right, up top that they're safe and efficacious.
Yeah.
Okay, so
And then I think, not to be nitpicky, but I would say instead of just both alpha agonists, I would say both non-stimulant alpha agonist, just because otherwise we're not calling out at all that this paragraph is just about the non-stimulants, even though it's redundant.
like that?
Yeah. And then alpha agonists plural. Perfect.
And at least one non
One
alpha.
non-stimulant.
Like,
Wait,
well, yeah,
one
in the
non-alpha agonist.
the original language
It would
says
be a
at least
non-stimulant,
one
non-alpha
Yeah,
non-stimulant
agonist.
that
that
is
is
not
not
an
an
alpha
alpha agonist.
agonist.
So I'm sorry, you guys were speaking at the same time. So I moved up both non-stimulant alpha agonists and at least one non-alpha
One
agonist.
and
One
then
non.
one non-stimulant. So just copy what's in the second paragraph. At least one non-stimulant that is not an alpha agonist.
Like this here.
Yeah,
And then put that here.
correct. Both non-stimulant alpha agonists was one more be added to the preferred Washington State preferred drug list.
Yeah, so just it says should be included as a preferred drug. So you can just delete
Thank you.
that part.
How does that look? And this will be deleted.
Just one, yeah, little typo. And it says and a at instead of just and at.
Oh.
Yeah, but that looks good.
And then do we need to put back in the top of this that they are safe and efficacious?
So that also can be combined in that first paragraph then, right? That all these agents are considered safe and efficacious.
Yeah, I think I move that methylphenidate-based and amphetamine-based agents of both long and short-acting formulations, as well as non-stimulants, comma, are safe and efficacious, something like that.
Yeah, is that um okay with the committee just to say non-stimulants instead of, again, writing out
I think
alpha,
that's okay.
all that stuff?
Sorry, Zoe, can you say that again? I'm sorry.
Yeah, no, so you're right so far. So just as well as just non-stimulants,
Okay, thank you.
I think that's fine. I mean, in a lot of them, we do call out every single drug, but I don't really know that that's necessary. So maybe this is our protest.
How
It's
does that
all in
look?
one page now.
This is Laura again. So I feel like if we do that though, then this other part of adding to the formulary about the long and short acting formulation, which I think is what Peter was getting at originally, then we should just include this in the second paragraph because really the second paragraph is addressing then what we're going to add to the preferred drug list, correct?
Mm-hmm.
Or we could combine it all into one too, because we say after considering the evidence and safety, all of these things are safe and efficacious, and then we have all our little stipulations after that, and we don't have to break the stipulations up. Say a long and short acting formulation should be present. They shouldn't be subject to therapeutic interchange, and then both non-stimulants should be present, at least one non-stimulant, that's not an alpha agonist should be present. So we could just delete the second after considering the evidence of safety and efficacy, blah, blah, blah. I move that and just have that count as the top. It says that already.
Yeah.
Remove that.
I think we can.
Yeah, and so the first part is just saying that all of these are safe and efficacious, that the long and short acting of each stimulant formulation should be on the preferred drug list, that the stimulants shall not be subject to therapeutic interchange, that both of the non-stimulant alpha agonists and at least one non-stimulant that is not an alpha agonist. So I think that captures the spirit of the
I think that
discussion.
says everything, yeah.
It'll have it look like this.
Actually, you'll need to take out the I move
Yeah, we
Oh,
don't need that one.
that and just say both. You capitalize the B for both. Okay.
It
And
looks like,
then,
yeah, just like a line break. Yeah, perfect. Yay. It's so much
okay.
shorter.
So do we have a
It's in
motion?
one page.
Yep. Do we have a motion?
Here, I can read the motion. This is Greg Hudson, and after considering the evidence of safety and efficacy and special populations for the treatment of attention deficit hyperactivity disorder, ADHD, I move that methylphenidate-based and amphetamine-based agents of both long and short-acting formulations, as well as non-stimulants, are safe and efficacious. A long and short-acting formulation of each stimulant should be on the preferred drug. Should be preferred drugs on the Washington State Preferred Drug List. The stimulants listed shall not be subject to therapeutic interchange on the Washington Preferred Drug List. Both non-stimulants, alpha agonists, and at least one non-stimulant that is not an alpha agonist should be included as a preferred drug on the Washington State Preferred Drug List.
I can second Zoe Taylor.
All in favor, please say aye.
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 Bravo, and the motion carried.
Can we get rid of the S after non-stimulant? Should be both non-stimulant alpha agonists.
Yeah,
The
right.
underlined. Nonya, the underlined one there.
oh, okay.
Yeah.
That.
Like
Yep,
that?
there you go.
And
Yep.
then also deleting
Oh,
the
wait.
end of that
It's
word.
still got an S on the end. Both
Oh.
non-stimulant.
Perfect. Yay. We don't need to revote.
Do we need to revote?
Not for the S.
Now,
Executive decision on that one.
Does it say leave it?
And sorry, Ryan, did we need to vote to make sure the surveillance was accepted as adequate?
uh, Yes, yeah, this was a surveillance document, so yeah, that needed to be
Voted
done
on.
prior to the motion.
Okay. I, Kavita Chavla, propose that the surveillance was accepted as adequate.
I'll second Peter Barquette.
All in favor, please say aye.
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 Do we need to re-vote on the motion, Ryan?
No, I think that should be fine.
Okay. I believe we have earned ourselves a 10-minute break, I think.
Do
Go
I'm
ahead.
so sorry. Did you want to adjourn the PNT part before we do the break?
Yeah,
That
we
way when you
can.
come
And
in, you
before
can
there's
just
any business, yes. Thank you, Nanya. And before there's any other PNT business before I adjourn?
nope, nothing from
Okay.
me.
Great. So with that, we adjourn the PNT portion of the meeting today, and we will see you back in 10 minutes.
Mhm.
Thank you, DUR presenter Shannon, and
Wes.
thank you, Wesley.
It's okay. I was talking to him earlier, so that's why I remembered.
Thank you, Nanya. And as our committee members are coming back, I would request that you please turn on your video. Great. I think we have our committee back. Okay, and so with that, we convene our DUR board. And I think we start off with Ryan Takatomo is going to take us through the drug utilization data.
Yep.
Hi, Ryan.
Hello. Hi, this is Ryan. And then Marissa, are you going to be presenting?
Do you want me to present for you, or did you have your slides all ready to go?
If you're able to present, that'd be great.
Yeah, hold on one second. Let me just get it all set up.
Okay, thanks.
Okay, you should be able to see it. Hopefully you can.
We
This Ryan.
Yes, we do.
Okay. All right. Good afternoon, PNTM. Today I'll be doing a continued presentation, looking at the anti-diabetics drug class. Next slide, please. So a little overview of the presentation. We'll do a little bit of recap from the previous drug utilization activities, and then we'll be looking at some new content that kind of takes a look at GLP-1 agonists and looks at ICD-10 medical claim diagnoses and their uses. Next slide, please. Okay, so this was just the top 25 classes by net pay, looking at the PMPM or per member per month increases from 2021 to 2023. One of the classes that stood out at that time was the anti-diabetics class, as it moved from the sixth most expensive class to the third most expensive class over time, with the significant increase from $1.51 PMPM to $2.67 PMPM over a 2-year span. Next slide, please. Okay, and then on this slide, it just kind of breaks down the different subclasses of the anti-diabetics. And a large driver to what we're seeing with anti-diabetic expenses are associated with the GLP-1 agonist class. These continue to be the hot drug of topic today, and we know that looking to the future, they will likely continue to be a challenge getting access and paying for these therapies. We can see the GLP-1s were the most expensive class in 2021, and they've increased probably 75% or so to 2023 as it goes from $1.51 to $2.67 PMPM. Next slide, please. Okay, and then here are just two graphs looking at the net paid over time, and then the number of clients who have used each of the different GLP-1s that were available. A majority of utilization comes from our preferred product, Victoza, but we are seeing a slow but continued growth of our non-preferred products, which include Ozempic and Trulicity. Next slide. All right, so now we'll be looking at the new content, which incorporates both pharmacy and medical claims. The date ranges were from January 2020 to end of June 2024 for the pharmacy claims data. And then for the medical claims, we went back an additional 2 years to 2018 for a look back period. What that means is if someone filled like a GLP-1 on January 2020, we looked back 2 years to January of 2018 to see if they had any ICD-10s for like diabetes, obesity, etc. Okay, next slide, please. Okay, so we're first looking at the number of clients that has each of these diagnoses. These diagnoses are mostly related to our current policies for GLP-1s and then our Wegovy policy. In addition, we started to include some diagnoses that were in the pipeline and may receive FDA approval at a near future date. When we look at the x-axis, they're all based off of 20,000, so it helps to give an idea of the percent of the population that has each of these. It means that for a big majority, obesity, type 2 diabetes are kind of like the primary diagnosis that, or a common diagnosis among all the clients using a GLP-1 agonist. And then it'll start to trickle down as it continues through like dyslipidemia, hypertension, sleep apnea, nicotine use. Next slide. And there'll be a few more ICD-10 diagnoses categories. So CKD, chronic kidney disease, carotid artery disease, peripheral artery disease, stroke, myocardial infarction, metabolic syndrome, and then coronary artery disease. And so for this slide, we just have the number of clients that have used a GLP-1 product, and we've separated it by plan, and then we have the total number of clients under the total, and just yeah, so looking at the chat there's a comment from Dr. Barkat saying the numbers for 2024 only represent data up to June 30, 2024, so only a half years of data. Next slide, please. Okay, and then this is a graph over time looking at which clients were using which GLP-1s by year and quarter. And to note, only one client was counted once for each time period based off the last claim that was filled. So looking at the most recent quarter, the majority of utilization kind of reflects the previous slide where majority of clients are using liraglutide, which is the generic formulation of Victoza, and then Victoza. The third product is semaglutide. We're doing some investigation to understand what that means. It was during a period where there may have been a shortage, and so there could be compounds or pharmacies dispensing some type of compound product. It may be related to data claim or data integrity issues from the pharmacy claims. But it's interesting that that kind of comes up in addition to the brand semaglutide products, which are the Ozempic and the Wegovy. Okay, next slide, please. Okay, so this first analysis will be focusing on the GLP-1 policy. We try to mimic our analysis based off the inclusion. We try to mimic the inclusion criteria based off of the policy requirements. So there were two categories. The first category was if a patient has type 2 diabetes with established cardiovascular disease or multiple risk factors. If they didn't meet that, then we are making the assumption that they met policy criteria based off trial and failure. Some of our assumptions include that the patient has appropriately met all trial and failure criteria, that the patient appropriately met the A1C requirement, and that the ICD-10s reported on claims are accurate and appropriate as well. Next slide, please. Okay. So on this slide, we have the number of clients on the top graph that met criteria, and the colors differentiate whether they had established cardiovascular disease or multiple risk factors, or if they met trial and failure criteria. Trial and failure is represented in orange, and then the established cardiovascular disease or multiple risk factors are represented in the dark blue. And then the bottom graph just shows the proportion out of 100%. So I think it's interesting that when you look at kind of the trend on the bottom graph, it starts out where more patients or clients we're meeting trial and failure criteria, but as time goes on, a significant greater amount of the population are kind of meeting criteria based off established cardiovascular disease or the multiple risk factors. Okay, next slide, please. Okay, on this graph, we are splitting out that data by the different health plans and fee for service. Note the y-axis is specific to the plan's population, so they're not equal. And I think just the takeaway is that amongst all the managed care organizations and fee for service, it's kind of following a similar trend with greater use of these products. Okay, next slide, please. All right, and so on this slide, it's split into two. This is focusing on the preferred GLP-1 products. On the top graph, it represents the number of clients using one of the preferred products that had established cardiovascular disease or multiple risk factors. And then on the bottom, it is type 2 diabetes without established cardiovascular disease or multiple risk factors, meaning trial and failure. And so for these, it does look like the majority of clients are using oh, never mind. Sorry. Next slide. Okay. Okay, yeah, and then for this slide, we're looking at the graph of the non-preferred products over time. And then again, the top is the established cardiovascular disease or multiple risk factors, and then the bottom represents the trial and failure.
Hey, Ryan.
Does yes.
Hey,
Go ahead.
I guess I'm a little confused about the semaglutide by itself instead of showing up as Ozempic or Rybelsus, because the generic is not out in the market. And as I understand, insurances don't cover compounded like, those freestanding compounded formulations. So can you help me understand what the big blocks of just semaglutide are?
Yeah, for that, we're not entirely sure yet at this time. That's an issue we're going to investigate. But for some reason on our pharmacy claims, that was what was coming across as our label name. Typically, it should be Ozempic or Wegovy, etc. But it might be something to do with data integrity. It's something we're trying to investigate and better understand.
I see.
But unfortunately, we don't know the exact reason at this time.
Got it. Thank you. I mean, I don't see Wegovy there, so I don't know if it's a placeholder for Wegovy.
It could represent either Ozempic or Wegovy, maybe even Rybelsus. But at this time, we're based off the data so we were not able to discern which product it was. Okay, next slide, please. Great questions. All right. And so for this portion, we're going to be looking at the Wegovy analysis. Again, the inclusion criteria are doing the best we can to mimic the policy criteria using ICD-10s. So we're looking at clients that had a diagnosis of obesity or overweight. They had established cardiovascular disease and no diagnosis of diabetes. Some of the assumptions we're making is that we assume the client or patient doesn't have an A1C greater than 6.5%. Since we don't have A1C data, we're assuming the patient is receiving appropriate therapy on the policy, for example, antiplatelets, antihypertensives, lipid lowering therapies, and then the ICD-10s that are reported are again accurate and appropriate. Okay, next slide. All right. So in this slide, it's split out by whether or not a client using Wegovy met policy criteria. We do want to note the y-axis, which is a maximum of 30, so not a significantly large population at this time, but just something to take note of. And so we do see that over time, the majority of patients that have been accessing Wegovy have not met policy criteria, but does seem to be some growth at the more recent year quarters. I would like to add that the pharmacy claims data includes all pharmacy claims. So this might be patients who have third-party liability, meaning Medicaid pays as a secondary payer. In those cases, they might not go through the prior authorization review process, and those might just be paid since Medicaid secondary. So just something to take into consideration when we look at the data. Okay, next slide, please. And then on the slide, it's breaking out which clients met criteria by the different plans. At least for this time period, fee for service did not appear to have any Wegovy utilization, so it is not listed. And then the y-axis is kind of specific to plans as well. Okay, next slide, please. And then on this slide, it groups up the clients and then splits it out between the different age groups. So on the top is the number of clients who are less than 21 years of age. And on the bottom, it's the clients who are 21 years of age or older. We chose 21 as the cutoff due to the EPS DT program requirements. And EPSDT stands for early and periodic screening, diagnostic, and treatment for reference. Okay. All right. Next, yep. Okay. On this slide, we're starting to look into investigational uses, off-label uses, or just indications that are just not currently covered from regulation requirements. So this first one is looking at GLP utilization and predicting the use for weight loss. For the data to be included in this, they had to have no diagnosis of diabetes, and they had to have a diagnosis for obesity, which includes, but is not limited to, overweight. For adults, a BMI of 27 or greater. For pediatrics, a BMI of the 85th percentile or greater, or obesity. And then assumptions, we're assuming that GLP-1s that meet inclusion criteria are being prescribed for weight loss, and the ICD-10s are accurate and appropriate. Next slide, please. Okay. So this is just you looking at all GLP-1s and then how many clients are meeting this criteria over time, over a year, quarter basis. And we do, as expected or anticipated, see just a continued increase in use of these products. Next slide. This is the breakout for the number of clients meeting the inclusion criteria split out by plan. And again, the 2024 is a bit lower because it only represents data up to June, the end of June of 2024. All plans do appear to follow a similar trend with continued growth over time. Next slide, please. And then on this slide, it just breaks it out by the age group. There doesn't seem to be a significant amount of the population under 21 using it for weight loss. And the majority is focused on the 21 and older population. Next slide. Okay, and then I think this is the last slide for this piece, but this will look at which label name, which drug is being used for weight loss. So we see that the top two drugs are again Victoza and liraglutide, which are preferred products. They currently do not have prior authorization. The next category or next drug category is that semaglutide, followed by Mounjaro, Bydureon, and then Ozempic. Okay, next slide, please. One of the indications currently in the pipeline is use of GLP-1s for sleep apnea. So this is something we were interested in, took a look at. So to meet inclusion criteria for this analysis, clients had to have a diagnosis of both obesity and sleep apnea, and then no diagnosis of diabetes. This will essentially kind of be a subset of the population we were just looking at, which was using it for weight loss. And then for the assumptions, we're assuming that patients that meet this inclusion criteria are being prescribed a GLP-1 for sleep apnea and that the ICD-10s are accurate. Next slide. Okay, and then here is the number of clients over the year quarter period that met this criteria. And we just see a trend moving upwards over time. Next slide. Here are the number of clients meeting criteria split out by plan. Again, they all kind of follow a similar pattern. Does look for fee for services, kind of maybe some greater intake in 21 and 22, but the numbers are relatively small with a maximum of 22 for fee for service. Next slide, please. Okay, and then this is just a breakout of how many clients are using the drug for sleep apnea by the specific GLP-1. And it kind of seems to look like what we've seen in previous slides, where the majority, again, are the preferred products, which are the Victoza generic version. This seems to make the most sense since they are preferred with no prior authorization requirements. And then it's followed by the semaglutide, Manjaro, and then Vidurion, and then Ozempic. Next slide. So that kind of concludes the presentation. And based off trends, we continue to see continued growth for GLP-1s, especially as they continue to seek new indications. This is something we plan to bring back again at a future PNT, looking at these pipeline indications. These include heart failure, diabetic retinopathy, fatty liver disease, polycystic ovarian syndrome. And so, again, as this drug class continues to expand on its uses, we anticipate greater use of these products, which will provide just a continued challenge for providing access and paying for them. So with that, thank you for your time to listen to this presentation, and I'll open it up for any questions or comments.
Thank you, Ryan. Lots of great data and interesting information there. Comments from the committee, questions?
I just wanted to verify what you had said earlier to Peter's comment in the chat that the data for 2024 is up to June. Is that correct?
Hi, this is Ryan. Yes, that's correct. Up to June 30, 2024.
Okay, thank you.
Does HCA do more like total cost of care kind of analysis in terms of, we're spending more money on Ozempic, but is it preventing hospitalizations? Is it preventing amputations? I guess like just looking at pharmacy spend, it looks terrible, right? It's like scary. How are we going to pay for all this? But like the whole point is that it's going to help keep people well. So does HCA do that kind of analysis as well for predicting?
Hi, this is Ryan. We don't have anything as of yet, but we appreciate that feedback, and it's something that we can take into consideration to try to provide as a future activity. But yeah, right now we're dipping our toes in water, trying to get an understanding for how all this developing like the process to pull the data, analyze it, create a presentation, and so. I think that's a great idea, and it would be valuable to be able to look at the total cost of care.
Zoe, ICER, the Institute for Cost Effectiveness Research, looked at some of this, not as much as you'd like. They had some stuff from I think a couple of years ago on this, and at the current prices for like Ozempic or Wegovy, it's not, the cost effectiveness is not very good. But I think what a lot of people are interested in is, would it be good with liraglutide going generic? So probably worth kind of redoing that. With the other health plan that I work with, we did some of this research, not necessarily for the management of diabetes, but looking at just weight management more generally, and and strategies for weight management. And at that time, assuming the higher cost of drugs, like surgery was way more cost effective still, because the total cost of care doesn't go down by that much after weight loss. But it'll be interesting with true generic liraglutide, I think, coming out in the end of this month. all those calculations, I think, are going to get turned on their head a bit. Oh, Ryan, I had a question for you. The kind of stalling out in the second half of 2023, like a lot of the utilization kind of almost plateaued for a while. And I was wondering if you guys are attributing that to drug shortages, or if you think that kind of the people who are interested in a GLP-1 agonist have kind of found it and gotten it, and utilization might not go much higher. Curious where you come down on that. It sounded during the presentation like you are anticipating more and more patients over time, and maybe you would lean toward that being an effect of the drug shortages.
Hi, that's right. Yeah, that's a great question. I don't know the exact cause, but for me, I personally think that it kind of plateaued as the COVID expansion that allowed more clients to access the program that ended. And so the number of clients enrolled in Medicaid has dropped down significantly since that program ended. So that's my first thought as to what is causing that kind of plateau.
So, so higher utilization rates, but the number of patients in Medicaid going down. Okay.
Correct.
Think along, Kavita here, along the lines of what Zoe was asking, one of the challenges that I realize payers face is you may not continue to cover the same member over their like or 5 years, let alone their lifespan, and hence to see the benefits bear out of these medications, which are indeed over the span of 5 to 10 years, not anything in the immediate future. So all of that to say, is there a way to track, do like a sub-analysis of these members to see how many of these have actually been in the HCA system for 3 years or longer, or something like that, and then do that analysis of, well, did it actually result in a lower total cost of care? Does that question make
That's
sense?
right. Yeah, I think that makes sense, and something again we can take back as feedback to try to incorporate as a future presentation. I do agree that when it comes to an Apple Health Medicaid population, client enrollment is not stable in that clients enter and leave Apple Health all the time. I have seen that when it comes to like continuation of care, when they're jumping from one insurance to another, some plans might cover it, some plans will not. And I've seen that when patients do not have access to these therapies, the weight benefits at least tend to revert. And it highlights, to me, it highlights that there's a also greater need when on these therapies to try to correct the behavior that's causing just the weight gain in general. Sometimes it's manageable, sometimes it's not. I understand, but just something that I kind of think of and note.
Yeah, yeah, I agree with that. And then the other analysis I was wondering about was, the graphs that you showed about how many of the patients with diabetes who were on GLP-1 receptor agonists had concurrent cardiovascular risk factors, which is great to see that, for over the years, it's only gone up, and a very small subset of patients don't have cardiovascular risk factors if they're on these expensive medications. From a patient-centric standpoint, and to understand what practice patterns are, which probably won't really serve you in terms of drug utilization. It would be helpful to also see how many patients who do have diabetes and cardiovascular risk factors are not on GLP-1s, because the benefits for those patients is so huge from being on these medications. So from a clinical standpoint, I'm really curious to see like how many PCPs have actually adopted the evidence-based guidelines now for the past 5, 6 years. But yes, I can see that may not, as I'm saying it out loud, it may not really serve a purpose to the DUR.
That's right. No, I understand. It's great feedback, and definitely another idea to add to the list of future content to bring to this meeting.
So this is Laura. So it'd be interesting too, as far as medication management, to review each patient that's on a GLP-1 to see their overall medication utilization decreases, because as you treat the obesity, you should decrease hypertension, diabetes, so their overall medication that they're using, the number of them would decrease. So it seems like that might be something easier to track.
Yeah, good point. Although it may not be cheaper in the short run because, antihypertensives will probably be cheaper all the way for a long time to come compared to GLP-1s. But at least, yeah, the pill burden for the patient, right? Yeah. Yeah, what a great discussion. Other comments from the committee or questions for Ryan? No. I guess, Ryan, is there other drug classes that are being planned for future meetings? We've seen, I think, the anti-diabetics now a couple of times. Are there other families that you're considering?
Hi, it's Ryan. At least right now, we're thinking the next one again will be GLP-1.
Okay.
And then after that, it's a bit more open, and we're discussing potential topics. If you have any ideas that you think would be interesting to see or beneficial, we're happy to take those suggestions and try to bring that to the board, or bring that to the committee.
I guess, I won't be there, unfortunately, to receive it. But one of the topics that's coming up this afternoon, I know that there's been a lot of changes in how migraines are being managed, especially with the CGRP inhibitors. And so whether that, what is that translating into in terms of cost? For the longest time, we had these really cheap prophylactic meds, right? Which also were not that effective as the CGRPs. But anyway, that was the other.
That's right. No, that's great feedback. Thank you.
All right. Well, thank you, Ryan. I see we are 10 minutes ahead, 12 minutes ahead of schedule. Nania, I guess I'll look to you. Should we take a lunch break now? And also, I guess the committee, should we take a lunch break now? Let's start there. Or do you want to try to squeeze in a topic or something? Okay, lunch break now. How many say yes? Yes, yeah, I'm seeing some nodding, some neutrals. Okay, we'll just take a lunch.
We can do the lunch break. That's fine.
Okay. All right, that sounds great. So 30 minutes?
Yes.
Okay,
Thank
so
you.
10 past 2. Okay, wonderful. We'll see you then. Make sure all our committee members are back before we get started.
We're waiting for Zoe. Oh, there you go. We are
We go.
quorum.
All right, now that Zoe's here, we can get started. All right. I see next on our list, we have Luke Dearden, who's going to be presenting about migraine agents.
And this is Marissa. Luke. I'll present for you. So whenever you're ready. Hopefully it's displaying.
Yeah, I can see it. Thanks, Marissa. So, good afternoon. My name is Luke Dearden, and I'll be presenting the updated migraine products CGRP antagonist policy. The primary update is that the acute treatment policy and the prevention treatment policy I guess, are currently two separate policies, but this combines them into one policy. Most of the criteria, though, remains pretty similar. So I'll start with the indication of migraine prophylaxis, and I'll run through the criteria briefly. So preferred products may be approved if the patient is 18 years of age or older. Criteria 2 specifies that the CGRP antagonists indicated for migraine prophylaxis will not be used in combination with each other. Number 3 is ensuring they have an appropriate diagnosis. Criteria 4 requires documentation that the prescriber has ruled out medication overuse headaches. Criteria 5, the patient must be experiencing 4 or more migraines per month. And criteria 6, patient has tried and failed at least one agent from 2 of the listed classes below. So anticonvulsants, antidepressants, beta blockers, or angiotensin receptor blockers. And the specific drug products are listed in the preferred therapy table below, which I guess, Marissa, we can get to later. Or yeah, you can scroll down right now. Yeah, preferred therapies. So those are the specific products. And then moving, yeah, any questions on that?
Kavita here. Sorry, I was just wondering if like amitriptyline is listed, but nortriptyline is not. Was there a reason for that?
Yeah, great question. So the products listed in this preferred therapies table are taken from the American Academy of Neurology migraine guidelines. And these are the products with the best evidence. I will note that a more recent, I believe it's from the American Headache Society, they had a position statement that did list products like nortriptyline, and also duloxetine was listed in that. I think it's reasonable to include those medications. I'm definitely open to the committee's feedback on that. But for this presentation, I just left it com compliant with the American Academy of Neurology guidelines.
Kavita here. Yeah, I totally see that reasoning. That it sounds logical. The reason that I bring that up is nortriptyline tends of the two, nortriptyline and amitriptyline. Nortriptyline usually is the one that we would go for because it has a slightly better side effect profile. So it would be Anyway, having said that, it's not like that's the only agent I would try my patient on. I'll probably hit one of the other ones on the list. Probably just not another antidepressant. I don't know. What does the committee think about?
I completely agree with you about nortriptyline, and I think whenever we get to the right time to do that, I would agree with adding it here if appropriate.
Yeah, this is Greg. Kavita, I'd second that, but I also would include duloxetine just in terms of if we are including it an antidepressant or an SNRI, with duloxetine just having a better tolerability than venlafaxine.
Vaccine.
Yeah, I think that's totally reasonable. So Maybe Marissa, can you add a note and we can add those agents in there? All right, awesome. So, I guess moving to the reauthorization criteria for the migraine prophylaxis. Or actually, first, there's a section in this policy that addresses non-preferred products. So that's the atogepant, the eptinizumab, and the rimegepant. They can be approved basically if two preferred CGRP receptor antagonists on the Apple Health preferred drug list indicated for migraine prophylaxis have been ineffective, contraindicated, or not tolerated. And then the reauthorization criteria, either migraine days reduced by at least 40% from baseline or documentation of significant improvement in the quality of life that can be reauthorized. The second indication is cluster headache, which the criteria is the same for this indication. So basically, appropriate FDA approved age, appropriate diagnosis, prescriber has ruled out medication overuse, and then failure of verapamil at a dose of 360 milligrams for at least 1 month, unless not tolerated or contraindicated. And then the reauthorization criteria ensures this medication, Emgality in this case, is effective at reducing the frequency of cluster headaches. And then finally, we have the indication of acute treatment of migraines. I'll note here that there was a new product that came to the market. It's Zavspret, and I added it to this policy. It's a non-preferred option at this time, but it is the first intranasal CGRP antagonist. So I thought that was notable. The criteria here also remain pretty much the same from the existing policy, and again include the appropriate age, the appropriate diagnosis. Number 3, again, is the CGRPs indicated for acute treatment cannot be used in combination with each other. Number 4 is patient must have experienced at least 2 migraines within the last 3 months. And then number 5, again, is the medication use headaches are ruled out. And number 6 is inadequate treatment to 2 different triptans, including an NSAID in combination with a triptan. And then also criteria for non-preferred products, which again, one preferred CGRP receptor antagonist on the Apple Health PDL indicated for acute migraine treatment has been ineffective, contraindicated, or not tolerated. And it's one because there's only one preferred product on the PDL for acute treatment. And then reauthorization requires stability or positive clinical response, defined as a reduction in pain or otherwise bothersome symptoms, like maybe photophobia, for example, or nausea. And then we already discussed the preferred therapies. The dosage and quantity limits table is included. And then I believe that's it. There is a background material, and then I believe there's diagnostic criteria for migraine included in the appendix as well. And yeah, this is the, oh, thank you, Marissa. Yeah. And then, yeah, this is the penned form, and this helps facilitate uh, prescribers submitting PA requests. And I'll invite the committee to take a look at it. And I'm happy to answer any questions. And I guess nortriptyline is listed here, so we'll have to add duloxetine.
I guess I haven't, Kavita here, I haven't done documentation for the re-auth stuff. I don't know if anybody else has insight on how do you document an improvement by at least 40% from baseline?
Was was that a question for
I
me?
guess to anybody who can answer it, like how do we, is it you, like do we use headache diaries to kind of show a reduction of at least 40% from baseline? Just trying to.
Yeah, I think from our perspective, that's again one of the options to achieve reauthorization. The other one is just documentation of improvement of quality of life. But if, for example, in the chart notes, you listed patient is experiencing, 6 migraines a month, and then 6 months later, when they need reauthorization,
Oh, I see what you're
in the
saying.
chart notes, it could say patient reports experiencing about 2 migraines per month now, and that would, meet the criteria.
Got it. Okay, that
Yeah,
works.
I don't know that it needs to be like an exact, like, where the patient has to record in a diary.
Okay.
Although that's great if that's your practice style.
Any questions from the committee for Luke or about the policy?
This is Peter Burkett. I have a question for Luke about the acute migraine indication for CGRP inhibitors. Um, there was some language in there about not using other CGRP inhibitors, but I think the way that it's written, it seems to imply other abortive agents, not necessarily prophylactic agents. And I wonder if we need to clarify the intent there. I also kind of wonder if we even need criteria here if step therapy would be fine. Like I'm thinking of this doesn't actually address some of the common situations in which I would consider using a CGRP inhibitor for abortive treatment. Like I have a patient with migraine headaches who also has high risk coronary artery disease, and he's on a couple of antiplatelet agents, and so we really don't want to use the NSAIDs and don't want to use the triptans. And under this criteria, doesn't really work for somebody like that. I assume that they'd probably end up getting approved anyway under medical necessity because those agents are relatively contraindicated. But usually people who are using abortive agents aren't using them nearly on the kind of in the quantities that people using prophylactic agents would be. I kind of wonder if, one, it's maybe would need a lot of work to adjust this criteria, and then is that even worth it?
Yeah, thanks for the feedback. So just to clarify, are you
Well,
suggesting
I guess
that?
what my suggestion would be, could we get away with step therapy? Like patient should have used an NSAID and a triptan unless contraindicated. And if they failed that, then maybe have a quantity limit if you're using it for the abortive indication, and really only stop it for a full review if you're going to use it every day for prophylactic reasons.
Yeah, I think that's good. That's good feedback. Well, we would have to take that back, and I mean, I guess I'd also defer to Marissa on this. However, I will say that in the patient you brought up with some coronary concerns, um, I don't, I don't know that step therapy would necessarily help with that. I mean, the patient would still be stopped for not trying a triptin, and then you'd have to explain why they can't use a triptin, and it would be effectively um, the same as this PA process.
Yeah, this is Marissa. I would have to double check to see if our system has that capability to do that. I don't believe we're utilizing or even have the ability right now to do that type of like step therapy edit, unless we do like a smart PA, for example, which disclaimer, I don't believe is working as we are intending right now, or correctly. And yeah, so I would have to double check on that.
Well,
My biggest advice is if it truly the step throughs are truly contraindicated in a patient, then you would just want to make note of that in the request, and then the clinical reviewer should be taking that into consideration for if it's appropriate or not for them to be stepping through those. And then that could be grounds for approval, at least from my take of reviewing cases.
mhm. Well, then I guess what I would suggest is in criteria number, let's see, criteria number 3, I would change the language to will not be used in combination with another CGRP inhibitor. And then in criteria number 6, I'll wait for you to make the change.
So, yeah, that's a great suggestion, and thanks for reminding me. The intent of this criteria does enable a member to use a preventive CGRP in combination with an acute CGRP if they meet criteria for both
Oh,
indications. So
that
that
is the
So
was
then
my
intent.
change it
intent.
back then.
What
Yeah,
was that?
Yeah.
I mean, if that's the intent, then I would leave it that way.
Yeah.
I think
Yeah,
the last
just
time I looked at the data on that, there weren't any studies, and I did like a market scan maybe a year or two ago, and wasn't aware of any other health plans covering 2 CGRP inhibitors.
yeah. So I can say that you're right, and I should have called this out when going through the criteria originally. The existing CGRP policy does not allow for that. However, this is a change, and there are studies that indicate it's safe to be taking preventive and acute CGRP therapy. And I'll also say that these criteria or these proposed new criteria align with our um, employee and retiree benefit plan policy for CGRPs as well, based on some of the newer evidence.
Okay, then I would go down to criteria number 6, and I think what I would say is, let's see, so documentation of inadequate treatment response to the following, and I'd probably just put in there, um, or those agents are contraindicated or something to that effect. I think usually the language I'm most used to is documentation of uh, trial and failure or contraindication. But yeah, yeah, I think
And
those.
there is that language in 6A and 6B already. I don't know if that addresses your
Was
concern,
contraindicated.
but
Oh, it is
either way
there. You're
works.
right. I missed that reading through it before.
This is Marissa. So we do, I believe in our site, we're trying to make language like this uniform across all of our policies. And I believe we started it in the cytokine and CAMs where we had like this language here in red. So I'm just remembering that and adding it here. I'm thinking that might meet the need, so then it's only in one place. But let me know if you want me to change it back.
No, I think that's fine if it's in on the individual agents. It's just what we were going through before. I was trying to work quickly and missed it. So you're on it. And thanks for clarifying about the new evidence of prophylactic and abortive agents. That's good to know.
Okay, great edits. Other questions? Have we seen all of the policy, Marissa?
I believe so, unless there's anything you would like me to go back to.
All right, and then did we have any stakeholders for this portion, Nanya?
Can you go down to the bottom of this, the authorization page? I just want to see for reauthorization here.
Okay, any questions about the motion? All right, then I'll ask again about stakeholders. Nanya, I don't see any listed on the agenda. Do we have any?
Yes, I have two hands raised.
Okay.
The first one is going to be Rochelle. Okay, Rochelle, you can unmute yourself.
Okay, thank you so much. My name is Rochelle Yang. I'm with Teva Medical Affairs. So Teva is the manufacturer of Jovi, which is an injectable CGRP inhibitor used for the prevention of migraine. It is currently preferred on the Apple Health PDL, so we do thank the HCA and the committee for making these medications available to patients. I did want to just add that this past March, the American Headache Society, or AHS, published an updated position statement regarding the CGRP therapies, where they now state that the CGRP targeting therapy should be considered as first line for migraine prevention, along with previous other first line options, without a requirement for prior failure of other classes of preventative treatments. So this replaced their previous consensus statement whereby individuals try at least two classes of prior first-line migraine medications before being considered for a CGRP targeting therapy. This was based on a review of the randomized controlled trials, post-hoc analyses, as well as open label extensions of these products, as well as real-world evidence showing high efficacy and tolerability with the CGRP targeting therapies. So currently, like Luke had mentioned, the policy for Apple Health does require a 3-month trial of at least two preventative drug classes. With the updated AHS position statement in mind, I would just respectfully ask the committee if you may consider a reduction to one step or removal of these trial and failure requirements within the policy, as we've seen some of the other state Medicaid programs decide to remove these steps recently. Thank you.
Thank you, Rochelle. Questions from the committee for Rochelle? Okay. Then our next
Yeah.
one. Yeah.
My apologies, Rochelle. I see you and Aaron. I had you guys listed under the drug class because they're going to be migraine agents. Just wanted to let you know that I recorded you, but not on the policy part. So sorry about that.
Okay, no worries. Thank you.
Uh-huh. Next person I have, it says iPhone. I don't know. T. Shriner, you can speak.
I should not be signed up for testimony. I'm not sure how that happened. Did I raise my hand?
Yes, your hand's
Oh, I
raised.
apologize. I don't know how that happened.
No problem.
Sorry.
Uh-huh. And next is Erin.
Hi, can you hear me?
Yes.
Great, thank you. Hello, my name is Erin Novak, Medical Outcomes and Science Liaison with AbbVie. Thanks for the opportunity to speak on atogepant or brand name Qulipta. This is an oral CGRP antagonist indicated for the preventive treatment of both episodic and chronic migraine. Now, this is not a new therapy, but I would like to provide some unique characteristics of atogepant as well as some updated information with the purpose of supporting a request today, and that is, in addition to the previous speaker, to reduce prerequisite therapy requirements based on AHS, as well as some other information I'll share here. So first, there are 3 characteristics of atogepant that I'd like to share. First, it is the only oral CGRP therapy covering the full spectrum of migraine prevention, offering a mode of delivery that is often preferred by patients and then offers a solution for patients with needle phobia, for example. Secondly, there is a shorter half-life versus the injectable monoclonal antibodies, which affords suitability for daily dosing and fast clearance of the drug in just a few days. Shall a patient need to withdraw therapy for any reason, such as if a patient becomes pregnant? And then thirdly, for episodic migraine, there are 10, 30, and 60 milligram tablets available, suitable for dosing flexibility, catering to patients' efficacy, tolerability, and or dose modifications that could be needed due to organ dysfunction or drug interactions. Additionally, in a cost per responder analysis, atogepant had the lowest number needed to treat compared to all approved CGRP therapies, as well as the highest relative clinical effectiveness based on phase 3 data when looking at the outcome of 50% response rate. Furthermore, real-world evidence suggests that atogepant switch rates may be lower of the therapies within the CGRP class. Please note that further efficacy and safety information can be found in the prescribing information at rxabbvie.com. And with the AHS position statement presented by a previous speaker, coupled with the clinical attributes that I shared just before, the clinical benefits of atogepant may be beneficial to patients as well as the state of Washington. Thus, I'm kindly requesting consideration for reducing the atogepant prerequisite requirements, which currently include those 2 oral conventional therapy steps, as well as 2 CGRP monoclonal antibody steps. Thank you kindly, and I'm also available for any questions that you might have.
Thank you, Erin. Any questions from the committee for Erin? Thank you. Any other stakeholders?
No. Excuse me. No, I do not have any other stakeholder hands raised.
Okay, great. And we can proceed with the motion. We have all our committee members back on camera, right on. Okay. All right, I propose move that the Apple Health Medicaid program implement the clinical criteria listed on policy 67.70.10-2 as recommended.
Peter Barkat, I'll second the motion.
All in favor, please say aye.
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 Any opposed or abstain? All right, with that, the motion carries. And we go to Ryan Takatomo to review the policy for oncology agents.
This is Marissa. Ryan, just give me 1 second. I'm pulling up the policy. Okay, should be displaying now.
Okay, good afternoon, everyone. This is Ryan, and I'll be going over the cyclin-dependent kinase 4/6 inhibitors. This includes abemaciclib, palbociclib, and ribociclib. Scroll down, please. And I'll just kind of walk through the criteria before opening up for discussion. And if there's any questions, no, feel free to interrupt me, and then we can address those as I go through it. So there's two kind of coverage indications we'll be going through in this policy. The first one is adjuvant therapy of early stage, which is stage 1 to 3 breast cancer. And so the only drug that falls in this category is abemaciclib or Zenio. This is the clinical criteria. Abemaciclib may be approved when all the following documented criteria are met. Criteria 1 is the patient is 18 years of age or older. And it's criteria 2, it's prescribed by or in consultation with an oncologist. And criteria 3, the patient has not previously progressed on or after treatment with another CDK4/6 inhibitor. And criteria 4 is a diagnosis of hormone receptor positive and HER2 negative breast cancer. And criteria 5, the request is for adjuvant therapy of early stage breast cancer. And criteria 6, the provider tests the patient has high risk breast cancer based on one of the following. The first one is 6A. They either have a histopathological test showing 4 or more axillary lymph nodes are affected. For example, PALN-N2 or N3 disease, or they have histopathological tests showing 1 to 3 axillary lymph nodes that are affected, and one of the three following include the tumor size is greater than or equal to 5 centimeters, or there's a histopathological grade 3 disease, G3, or the patient has a Ki-67 score greater than or equal to 20% as determined by an FDA approved test. And then for criteria 7, the patient has undergone definitive surgical resection of the primary tumor. And criteria 8, there's a history of failure or intolerance using one of the following treatment modalities. That is either radiotherapy, 8A, or AB taxane based, for example, docetaxel, or anthracycline based doxorubicin chemotherapy. And abemaciclib will be used in combination with an aromatase inhibitor. Examples include letrozole and anastrozole, exemestane, or tamoxifen, and it will not be used in combination with any additional oncology therapy. Once they meet that criteria, it'll be authorized for 6 months. For the reauthorization criteria, abemaciclib may be approved when all the following documented criteria are met. Criteria 1 is it continues to not be used in combination with any other oncolytic medication, with the exception of an aromatase inhibitor or estrogen receptor antagonist. And there's documentation submitted demonstrating disease stability or positive clinical response, for example, a decrease in tumor size or tumor spread. And then once that criteria is met, it'll be authorized for an additional 6 months at a time. The second indication or grouping, I guess, we're going over is systemic therapy of recurrent, advanced, or metastatic breast cancer. All the drugs are included in this indication in this policy. And so the criteria is as follows: abemaciclib, palbociclib, ribociclib, and ribociclib and letrozole combination may be approved when all the following documented criteria are met. Criteria 1 is the patient is 18 years of age or older. And criteria 2, it's prescribed by or in consultation with an oncologist. And criteria 3, the patient has not previously progressed on or after treatment with another CDK4/6 inhibitor. And criteria 4, there's a diagnosis of hormone receptor positive and HER2 negative breast cancer. And criteria 5, patient has a diagnosis of advanced or metastatic stage 3 or stage 4 breast cancer. And criteria 6, the medication is prescribed as a first-line systemic therapy. In addition to that, the medication will be used in combination with an aromatase inhibitor or fulvestrant, and it will not be used in combination with any additional oncology therapy. And the patient is a postmenopausal female, premenopausal or perimenopausal female receiving ovarian suppression or ablation, for example, surgical ablation, suppression with GnRH therapy like leuprolide. Or the patient is a hormone suppressed male, and GnRH therapy is used concomitantly. So it's 6 or 7. So the 6 again was first line, 7 is second line systemic therapy. So if it's second line systemic therapy, then the medication will be used in combination with fulvestrant, and it will not be used in combination with any additional oncology therapy. And the patient had progressed on or after primary endocrine therapy as adjuvant or first line systemic therapy. And the patient is postmenopausal female, premenopausal or perimenopausal female receiving ovarian suppression or ablation, or the patient is a hormone suppressed male, and then we have criteria 8, which is now the third line. So the medication is being prescribed for subsequent line, third line or later, systemic therapy in a metastatic setting. And for that one, the patient has had disease progression on or after endocrine therapy and systemic therapy not containing a CDK4/6 inhibitor in the metastatic setting, and the request is for abemaciclib monotherapy. So once that criterion is met, it'll be authorized for 6 months. So for the reauthorization criteria, the products may be approved when all the following are met. Criteria 1 is it continues to not be used in combination with any other oncolytic medication with the exception of an aromatase inhibitor or estrogen receptor antagonist. And there's documentation submitted demonstrating disease stability or positive clinical response similar to before. And then once all that criteria is met, it'll be reauthorized for 6 months at a time. And then we just have the dosage and quantity limits and some background information. So I think we can move on to the form. All right, this is what we call a pen form. It's used to help facilitate the PA process. Usually we use this in addition with chart notes. So I'll just leave it up for the committee to look over and then open it up for discussion. Thank you.
Thank you, Ryan. Questions from the committee for Ryan?
And Kavita, there are no hands raised.
For stakeholders? Oh,
For
great. Thank you for
stakeholders.
letting me know. Okay. Hearing none from the committee members. Marissa, I'll let you take us to the motion whenever you're done with the editing.
All right, this is Marissa. So I did make an update. I just added the policy number to that particular actual policy form. And then for the version, I just updated it. I believe on the slides you may have gotten for the policy motions, it was -2, but this is actually -1 because this is the first iteration of this policy that we're creating. So I just wanted to make that note.
This is Laura Bestie. I make the motion that the Apple Health Medicaid program implement the clinical criteria listed on policy 21.53.10-1 as recommended.
And this is
Greg,
Greg. It's a nice second.
All in favor, please say aye.
Aye.
Any opposed or abstain? Okay, thank you. That the motion carries. Next, I think Marissa, you stay on and you help us with the policy on calcitonin.
This is Marissa. Yes, that is correct. Let me go ahead and just pull up all of the appropriate forms for that. And then I will go ahead and get started. All right, let me turn my camera on here. All right. So the policy that I will be presenting today is for our bone density regulators, specifically the calcitonins. So I think it was October. I presented the other bone density regulator policies, which I believe were the parathyroid, RANK-L, and sclerostin inhibitor policies. And just to give everyone a refresher on those policies, we are currently breaking out all of our bone density regulator policies into separate ones. Currently, they all live in one, but we are separating them out, similar to what we are doing with our cytokine and CAMs, and it's really just by mechanism of action. So this policy, we're just adding into the mix. We weren't able to accommodate it for the October policy, so we're just going through it for the December policy. And this is the last of at least it should be the last of the bone density regulator policies that we have to split. So hopefully this is the last time you all see it, unless I bring it back. The products that this particular policy really affects is just calcitonin salmon, or miacalcin is the brand name for this product. So I'll go through it indication by indication. The first one is for hypercalcemia. And for this particular policy or this particular indication, we are planning on doing what's called an expedited authorization, because we acknowledge that hypercalcemia is more of like an urgent and emergent condition. What we're going to do for this particular indication is set up that EA where at the point of sale or at the pharmacy, if the pharmacist can see that the patient meets the diagnosis for it, if it's like written on the prescription, or hopefully our system has the ability to actually identify it by ICD-10 code, then they would input just a quick little EA code and then the claim will pay. So then they don't have to go through the PA process if they have the indication of hypercalcemia. So that's more, I don't know the logistics of operationally how that would work, and I'm not privy to speaking to it. Unfortunately, I don't have an operations person on our line to really go through that, but that's in retrospect, or prospectively, what we would want to do and how we would set that up. We do have EAs in place currently for other products, so it is something that we are capable of doing, but we would just approach it the same way. So that would address that particular indication. Where this particular product would hit really for a full PA is in the next following indications. So for Paget's disease, the criteria, I'll just go through it line by line. So the patient is 18 years of age and older, and they have a diagnosis of Paget's disease. The patient has symptomatic disease. So examples would be they're experiencing bone pain, nerve compression, bone lesions, fracture, things like that. And 4, baseline assessments of either of the following are included. So we would accept A, B, or C. in their chart notes when we look at that. So looking at serum alkaline phosphatase levels, a diagnostic radiograph CT or MRI, or biopsy results. And then 5, the last criteria is treatment with at least one preferred oral or IV bisphosphonate medication has been ineffective unless all are contraindicated or not tolerated. And the minimum trial for that would be 12 months. If they do meet all of the criteria, then we would authorize it for 12 months or 1 year. And then for the reauthorization, it's really just documentation is submitted demonstrating disease stability or a positive clinical response. So examples of that we would be looking for are improvements in their serum alkaline phosphatase levels or an improvement in their bone pain. And if they meet all of that, then the request will be reauthorized for another year or 12 months. The next indication that this would hit for really full PA is for postmenopausal osteoporosis. I will caveat this by saying and I know it was 2 months ago, the criteria that you saw in October, I pretty much carried over into this particular policy. So the criteria for postmenopausal osteoporosis is very much exactly the same across all of the bone density regulators. And I did that. We did that by design just because there's overlap with the different drugs. So just to keep it simple, I'll go through it again just because it has been quite a while since we've gone through it. But the first one is just age indication, 18 years of age or older, and they have a diagnosis of osteoporosis, and the patient is a postmenopausal female. And 4, at least one of the following fracture risk categories are met. So anything A, B, C, or D. They have a presence of fragility fractures of the hip or spine, regardless of bone mineral density, or they have a T-score of less than or equal to -2.5 in the lumbar spine, femoral neck, or total hip, or they have a T-score between -1 and -2.5 with a history of recent fragility fracture of the proximal humerus, pelvis, or distal forearm, or D, a T-score between -1 and -2.5 with a FRAX 10-year probability for a major fracture of greater than or equal to 20%, or hip fracture greater than or equal to 3%. And here for 5, it's just getting into the trial and failures. So they would just need to try or fail one or the other. So the first one is really just one preferred oral or IV bisphosphonate for a minimum trial of 12 months, or a selective estrogen receptor modulator, a SERM, has been ineffective unless all are contraindicated or not tolerated. That minimum trial is 24 months. And the duration, if it is approved, is for 12 months. And then the reauthorization is pretty much the same. We're just looking for documentation that they have disease stability or positive clinical response. So things we would be looking for in the chart notes are the patient has not suffered a fragility fracture, their bone mineral density continues to improve or remain stable. And those are just some of the examples. And then if it is reauthorized, it'll be for another 12 months. And so this is just getting into the dosage and quantity limits. It is broken out here by brand and generic. There is that brand product there. So that's why you'll see it kind of listed twice. And then we have that here, a little bit of the background. And then this is essentially, it's designed the same way, just a little bit different questions as the other pen forms that you saw in the last 2 policies. And I'll go ahead and pause there for any questions.
Thank you, Marissa. Gosh, calcitonin for osteoporosis just feels like such an old school like treatment, especially for that 4th criteria of, they just have a high FRAX calculated risk. And so I guess I'm just wondering about, is that from current guidelines? Are they still recommending that calcitonin can be an option for them? I don't know if you know or any other committee members might be able to educate me on that.
This is Marissa. I am not familiar with it. My memory is a little hazy, so I'm not quite sure. Um, but I can take a look and see and take it back to look.
Okay. I guess the only reason I bring that up is, do we even want to leave it open as an option?
I
Because
think, well, I'm just reading up to date. It says calcitonin may be effective, but it is less effective than other available agents. So I think as long as it's safe and effective, we probably do still need to include it because there might be a patient where that might be their only option for some weird reason. But I agree with you. I've never done that, and I never even knew this was a thing.
go ahead, Peter. Thank you so
Oh,
much.
yeah, thanks. Melissa, one thing I didn't see on there, maybe I missed it, and probably one of the few times I use calcitonin is for pain after compression fracture. Is that not an FDA approved indication? Is that off-label?
This is Marissa. I'm not familiar with that, and when I don't believe it is, but I would have to, unless things have changed. But at the time that I was working on it, I didn't see that it was.
I thought that was the 4A, presence of fragility, fracture of the spine. Wasn't that the 4A criteria?
Wasn't that embedded? You're talking about embedded within the osteoporosis diagnosis? I mean, I guess if
It
you have a
says
fracture, then
off-label.
okay. I guess if
Yeah.
you do have a fracture, then you're automatically would qualify for a diagnosis. So,
And
okay.
it says like indication is specifically osteoporotic vertebral fractures. So I think that's sort of what it's getting at.
Well, I think low impact vertebral fractures basically become the clinical criteria for
Sure. Yeah.
maybe
Fair.
that's what Peter was talking about. Anyway, that's how I read 4A, is if they had a spine fracture or vertebral fracture. Other questions? I guess, is there a limit on the number of times it can be reauthorized?
This is Marissa. I don't believe we put any limits on it. No, it doesn't look like there is, like compared to the other ones. And I
Like
didn't,
PTHRPs, like will have 2-year limits, things like that.
yeah, and from what I was looking at, when I was working on this policy, it didn't look like there were like certain limits, like some of the other bone density regulators. So I didn't include that in here, but I don't see that that is anything.
Peter, did you have another question? All right. In that case, hearing no other questions, Ananya, do we have any stakeholders?
No, no one's hands are raised.
And we can look at the motion.
And this is Marissa. I'm actually going to update this version here to 2 because this is technically a breakout. So just wanted to make that note for you all.
Okay,
Then
this
I'll
is
make
Greg.
the. Oh, go ahead, Greg.
Yeah, this is Greg Hudson. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 30.04.30-2 as recommended.
Peter Barkat, I second the motion.
All in favor, please say aye.
Aye.
Any opposed or abstained? Great. With that, the motion carries. And Marissa, are you taking us next to the musculoskeletal, I guess, fibrodysplasia agents?
This is Marissa. I believe so. Let me just pull up all of my documents for that.
You keep track of all of them, my goodness.
I have to keep most of them closed, otherwise I will get confused. So let me just get that all ready for you. Okay. Oh, great. All right. So I will just go ahead and jump right into it. All right, so now we're starting the actual AHPDL drug class reviews. So for this particular drug class, which is, it's named the musculoskeletal therapy agents, fibrodysplasia agents, there is only one drug that lives in that class, which is Sohonos. And I know that this looks a little different. We are trying, or at least moving forward, we might be doing, this is kind of a test phase of kind of doing these medication assessments for maybe newer products to market, or those drug classes where maybe there's only one, like the newer agents. So instead of you kind of what you're used to in the past of looking at a PowerPoint with like guideline information and drug information, it's kind of, we're thinking about organizing it more in kind of like this monograph type looking document. So I'm kind of testing it out. Let me know if you have any feedback for it. But I figured this is kind of the easiest way to ease into it right now, since it's only one product, and this class has never been reviewed before. So just to kind of walk you through it, it's a little easy. For this particular product, like I mentioned, it's Sohonos or palovarotene. And this is just some of the information that we will be including. And of course, there's room for improvement for some of the information that we're including here. So it was approved via the traditional FDA approval, and it was approved back in August 16th of 2023. So fairly new, a little bit over a year now and some change. Palovarotene or Sohonos, it is a retinoid. It is FDA approved for the treatment, and this is straight from the label, the treatment of reduction in the volume of new heterotropic ossification in adults and children age 8 years and older for females and 10 years and older for males with fibrodysplasia ossificans progressiva or FOP. It is an orally administered drug. It comes in a capsule, which is administered once daily. Just a very high level background on the disease state itself. So FOP, it's an ultra rare connective tissue disorder where the muscle tissue and the connective tissue are ossified, and which means that they gradually get replaced by the bone, essentially forming bone outside of the skeleton, thereby limiting a patient's movement. Generally, this disease starts very early in childhood, and it starts usually at the neck and shoulders and proceeds down the body, down into the limbs. For patients, they usually appear normal at birth, except for bilateral malformation of the great toes, which are characteristically short and laterally deviated. The first metatarsals typically are malformed, and the first toes have an absent or fused interphalangeal joint. The prevalence of it is approximately 1 in 2 million, so it's very, very rare. And there's no sex, racial, ethnic, or geographic predisposition for this particular disease. So the place in therapy and the guidelines, they recommend that management of FOP is predominantly supportive and focuses on the prevention of the flare-ups. So I guess the only real guidelines that I could really find are the International Fibrodysplasia Ossificans Progressiva Association treatment guidelines, and they were recently updated in July of 2024. Palovarotene or Sohonos is recommended still to be used in combination with the standard of care therapies, which I'll go over next. And the standard of care therapies really are just a brief four-day course of high-dose corticosteroids begun within 24 hours of a flare-up. And that's typically a prednisone 2 mg per kg per day, up to 100 milligrams. Or patients also use NSAIDs in conjunction with a leukotriene inhibitor, and those can be used symptomatically for the duration of the flare-up. And then there was also the option recommendation for topical NSAIDs that could have potential advantages, and that was recommended to really kind of limit the rate of systemic abortion of NSAIDs. So drugs that were mentioned, and it was just they're just applied to the area of pain. So specific medications that were called out in those guidelines were compounded ketoprofen gel, and it was specifically 5%, with an upward titration of 15 to 20%. In pediatric patients, they don't recommend using a gel that has more than 10% of ketoprofen. And then there's other agents that they recommend, such as the lidocaine patches, gels, creams, or sprays, and then also capsaicin cream. This is just getting into kind of the approval of Sohonos. So Sohonos was based on a single arm open label phase 3 MOVE trial, which included patients with FOP 4 years of age and older. Only patients with the ACVR1 R206H pathogenic variant were included in the efficacy analysis, and all patients in the pivotal study received palovarotene daily dosing with temporary dose increases for flare-ups. The dosing is weight-based and age-based, and a natural history study was used as an external cohort. The primary efficacy endpoint was the annualized change in the new heterotropic ossification volume from baseline to month 18, assessed by low-dose whole-body CT imaging. The mean annualized new heterotropic ossification was 0.4 centimeters cubed per year in patients receiving the chronic flare-up palovarotene treatment, and 20.3 centimeters cubed per year in untreated patients in the natural history study. The treatment effect was about 10.9 centimeters cubed per year. And you can see here some of the other statistics there. Some safety considerations for this particular drug is that some common adverse events were dry skin, arthralgia, pruritus, pain in the extremities, rash, alopecia, arrhythmia, erythema, headache, back pain, skin exfoliation, nausea, musculoskeletal pain, myalgia, dry eye, hypersensitivity, peripheral edema, and fatigue. And then contraindications specifically for this drug include pregnancy and hypersensitivity to retinoids or any component of palovarotene. There is also a warning and a precaution with this drug that include premature epiphyseal closure, mucocutaneous adverse reactions, metabolic bone disorders, psychiatric disorders, and night blindness. So the dosing for this drug really depends, like I said, on age and then also sex. So this first kind of bucket that I'll go through is for adults and pediatric patients, 14 years of age and older. So the recommended daily dose for this patient population is typically 5 milligrams daily. And then you stop daily dosing when flare-up dosing begins. And flare-up dosing, here's kind of what's in the labeling of it. So for adults and pediatric patients, 14 years of age and older, is 20 milligram daily for 4 weeks, followed by 10 milligram daily for 8 weeks. So that's a total of 12 weeks. And even if the symptoms resolve earlier, then you return to daily dosing of 5 milligrams. And then they have caveats here where if during the course of flare-up treatment, the patient has like worsening of their original flare-up, or they have a flare-up at another site on their body, then you would restart the 12-week flare-up dosing at 20 milligrams daily. And then for patients that have gone through the whole 12-week period and their flare-up symptoms haven't resolved, then the 10 milligram daily dosage may be extended in 4-week intervals and continued until the flare-up symptoms resolve. If the new flare-up symptoms occur after the 5 milligram daily dosing, so once they get down to that 5 milligram, then you can restart the flare-up dosing again. For the patients that are aged 18 to 13 years of age and they're female, and for males that are 10 to 13 years of age, so that's kind of one other bucket. The dosing for these patients is weight-based, so that ranges from 2.5 milligrams to 5 milligrams daily. And there's a table here that specifies the dosing that they should be using based off of their weight here. And then for the flare-up dosing, for this one, the initial flare-up dosing is once daily for 4 weeks, and then administer the lower lower flare-up dosage once daily for 8 weeks. So then that hits the 12 weeks. And then if the symptoms resolve earlier, then you can return to daily dosing. It's kind of the same as far as if during the course of flare-up, the patient experiences worsening of their flare-up or another flare-up, then you just restart the 12-week flare-up again, dosing with the week 1 to 4 dose. And then if their flare-up symptoms haven't resolved after 12 weeks, then it's kind of the same as above. You just extend the flare-up dose in 4-week intervals until the symptoms resolve. And like I mentioned, this is just the weight-based dosing. I did take a look at our utilization for calendar year 2023. And I did also look at Q1 and Q2 of 2024 because that's all that's available to me right now. And we didn't have any utilization in both our fee-for-service and MCO populations. So no utilization really since this product has come out. How we currently have it right now, it is currently preferred. There is a PA. We don't have criteria, and this document that I'm presenting is not by any means like proposing any new policy or criteria for it. It's really just an FYI of the drug that has come to market. But if we did create a policy for it, we would bring it here. So really any request that we get for this medication would be for medical necessity per labeling. And that's really how we manage it right now at this time. So I can take any questions from the board.
Thank you, Marissa. Yeah, the document is more linear, and so it's pretty easy to follow. Questions from the committee from Marissa? Okay. Nadia, any stakeholders?
Hello, there is no hands raised.
Okay. So then if there are no questions, we can review the motion.
Oh, this is Marissa. Let me actually just show you the PDL, even though I really went over it in the document, but just for completeness sake, this is just to show you what's going on our PDL. So like I mentioned, it is the only product in the class.
I
It
think
is
we're still
preferred.
in the document.
Oh, let me actually show my screen. There we go. Okay, there we go. So like I mentioned before, it is just preferred with PA on our PDL. And then let me pull up the motion for this. And I appreciate you all being patient with me going through that for the first time. If you have any recommendations on maybe other things you would like to see on that type of document, please feel free to let me know. So then we can add that for improvement, since this is kind of a newer kind of test run that we're doing for this type of review. But there's the motion.
This is Christy Weiland. I move that all product. Oh, are you adjusting?
Sorry, I just noticed that it was not correct. So there, apologies.
Yeah, no,
there you go.
yeah. I move that all products in the musculoskeletal therapy agents, fibrodysplasia agent drug class are considered safe and efficacious for the medically accepted indication and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Zoe Taylor, I second.
You all in favor, please say aye.
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 Any opposed or abstain? All right, with that, the motion carries. All right, and I think that takes us into our 10-minute break before we do the final stretch of this session and of this year. Everybody good with the break now? Yeah. All right. We'll see you back in 10, so 3:31. Nanya?
Sounds good.
Yeah. Okay, I think we have quorum.
Okay.
Great. Take
And
it away, Nina.
all right. Hi, DUR board. This is Nina Huynh from Prime Therapeutics, and I'll be tag teaming the rest of the topics with Marissa for today. So for the drug classes that I will be going over, we will review the disease states, any new updates from the past year, including guidelines, indication, dosage, and formulations. And then just as a reminder, the medication listed on the top in dark purple are the prime therapeutic market basket, and below in light purple are the HPDL drug classes. So the first one we'll be going over is the angiotensin modulators, antihypertensive direct renin inhibitor combos, direct renin inhibitors, the ARNI antagonist 2 receptor antagonist combinations. So the first disease state we'll be going over is heart failure. Heart failure is a common clinical syndrome in which symptoms result from a structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood. Heart failure may be caused by disease of the myocardium, pericardium, endocardium, heart valves, vessels, or by metabolic disorders. Heart failure due to left ventricular dysfunction is categorized according to LV ejection fraction. So heart failure with reduced ejection fraction is defined as LVEF less or equal to 40%, and is also referred to as systolic heart failure. Heart failure with preserved ejection fraction is defined as left ventricular ejection fraction at least 50%, and is known as HFpEF and is also referred to as diastolic heart failure. Heart failure with mid-range ejection fraction is defined as LVEF 41 to 49%. And the goal of therapy of heart failure with reduced ejection fraction are to reduce morbidity and to reduce mortality. Okay, the American Heart Association, American College of Cardiology, and the Heart Failure Society of America published a guideline on the management of heart failure in 2022. As this is well over a year old, I have included it here for reference. However, I do want to point out the fourth bullet point. They do recommend patient with heart failure with ejection fraction and NYHA class 2 and 3 symptoms to be placed on Entresto to reduce mortality and morbidity. Okay, on the next slide, we have Entresto Sprinkle. So in April of 2024, FDA approved a new oral pellet formulation for Entresto Sprinkle, which is a combination of sacubitril and valsartan. Entresto Sprinkle contains oral pellets within the capsule and can be substituted in patients unable to swallow tablets. It shares the same indications, warning, and dosage as the oral tablet formulation, and the film-coated oral pellets within capsule is supplied in 2 strengths, the 6 mg per 6 mg and 15 mg per 16 mg. And I'm happy to answer any questions on the angiotensin modulators.
Thank you, Nina. Questions from the committee for Nina? Thank you, Marissa, for the list.
Okay, so this is Marissa. I'll just go over those 3 drug classes on our PDL. So the direct renin inhibitor combinations, direct renin inhibitors, and the ARNI, neprilysin inhibitor ARNI antagonist combinations. So in these 3 classes, it's probably easier for me to call out what we do have preferred. So really the only preferred product out of all the 3 classes are brand name Entresto and generic Entresto, which is sacubitril valsartan, and that is preferred without PA. Everything else, we have Tecturna, aliskiren, and then the Entresto sprinkle, those are non-preferred. And I can take any questions from the board.
Great to see that the RNAs are actually preferred without a PA. That's pretty
Yeah,
cool.
that's awesome.
Yeah, and just to, I guess, make a clarifying statement in case anyone was curious. So the reason why we have the brand and the generic Entresto both preferred at this time is usually when a new generic comes to market, there's that kind of 6-month exclusivity period where maybe only one generic manufacturer is making it. So sometimes cost-wise, it is still most cost effective for us to prefer the brand. But we do acknowledge that there are some, it could be more expensive for the pharmacies, at the point of sale, for them to stock the brand in that case. So we do keep the brand and the generic, typically in these cases, preferred together or at parity for about 6 months. And then from there, we make the determination if we want to change status of the brand to become non-preferred. So I'm not quite sure exactly how long the generic has been out on the market. I would have to take a look at that. But we will reevaluate probably in the next coming months if we do need to change that status of the brand name Entresto eventually to non-preferred. So we're just kind of waiting that out, but just wanted to make that little statement there in case you were curious why that is.
Thank you, Marissa. Questions from the board for Marissa or Nina before we go on to stakeholders? Hearing none. Nanya, any stakeholders?
Sorry, I was speaking while muted. But no, there is no one to raise their hand.
Okay. It's interesting that this falls under anti-hyperlipidemics.
This is I think that actually might be mislabeled. Yeah, let me update that. Thank you for calling that out. This should be hypertensives. There we go. Thank you, Kavita. Let me change this as well. There we go.
Great. Thank you.
I can read it. This is Zoe Taylor. I move that all products in the drug classes listed on slide 3 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Laura Bestie. I second.
You all in favor, please say aye.
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 Any opposed or abstain? All right, with that, the motion carries. Thank you. And then back to Nina to review insulin-like growth factors and other metabolic agents.
Yes, thank you. So I'll be going over growth factors, and this is under Apple Health PDL, endocrine and metabolic agents, insulin-like growth factors, and natriuretic peptides. So the disease state we'll be going over is achondroplasia, which is ACH, and it is a skeletal dysplasia caused by a mutation in the fibroblast growth factor receptor 3 gene, which leads to inhibition of endochondral ossification and impaired bone growth. Typical clinical features include short stature, limb shortening, and a characteristic facial configuration. ACH is associated with medical complications including sleep apnea and sleep disorders, breathing, spinal stenosis, kyphosis, recurrent otitis media, and obesity, as well as functional limitations and psychosocial challenges. Management of ACH focus upon maximizing functional capacity and monitoring, preventing, and treating complications. Growth hormone therapy is not recommended and can potentially worsen the disproportionality seen with this population. And for vosoritide is the first FDA-approved therapy for ACH. So going into Voxzogo, which is the vosoritide, in October 2023, FDA granted accelerated approval to expand indication to increase linear growth in pediatric patients with achondroplasia with open epiphysis to include patients 4.5 months to less than 5 years of age. Previously, it had an accelerated approval approved for pediatric patients 5 years of age and older. And the recommended dose is based on patient's actual body weight, and the availability remains the same. And I am happy to answer any questions regarding the growth factors.
Thank you, Nina. Did you want to continue with the natriuretic peptides, or should we?
Oh yeah, and there were no updates for the natriuretic peptides.
Oh, okay. Any questions for Nina then? Okay, then Marissa can show us the table of covered agents.
All right, this is Marissa. So this is the endocrine and metabolic agents, the insulin-like growth factors, and natriuretic peptides. So there is only one product in each of those classes. We have Increlex brand name and Voxzogo, which Nina just went over. Not very much going on in this class. Both are preferred, and we do have PA on those products. So I can take any questions from the board.
Clean and simple. Thank you, Marissa. Any questions from the board? And if not, Nania, please let us know if there are any stakeholders.
No, no raised hands.
Okay, then are we maybe ready for the motion? I, Kavita Chawla, move that all products in the drug classes listed on slide 5 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized, unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Greg Hudson, a second.
All in favor, please say aye.
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 Any opposed or abstain? Okay, that the motion carries. Right. The next is a nice bite-sized chunk of multiple drug classes. Nina and Marissa, you're gonna double team this one.
This is Marissa. Yes. So Nina will just go through really just kind of the updates that she has, and then after that, I'll just go straight into the review of the PDL, and then we'll do any stakeholders, which I believe there are quite a few,
Yeah.
and then the motion. So we're in the home stretch here.
Excellent. Take it away.
Okay, and this is Nina, and I'll go over androgenic agents, endocrine and metabolic agents, androgens, testosterone. And for this, there's only two discontinuation in the last year. So in December 2023, Endo discontinued for Testa, which is the testosterone gel meter 10 milligram per 0.5 grams, and the generic remains. And then in September 2024, FDA announced that Pfizer will discontinue marketing of depot testosterone injections, and the generic remains for that as well. Okay, and then the last topic I will be going over is the PAH agents, oral and inhaled. This is the Apple Health drug classes endothelin receptor antagonists, PDEIs, prostacyclin receptor agonists, prostaglandin vasodilators, and SGC stimulator. And all within that class, there's only one discontinuation. So in May 2024, Actelion Philips Respironics has announced discontinuation of the INEB AAD system, as well as associated supplies such as their medication discs used for administering the solution. Ilapros Ventavis solution in the strength of 10 microgram per ml and 20 microgram per ml is also being discontinued. And that concludes my portion of the presentation. Thank you, everyone.
Thank you, Nina.
So this is Marissa. I will just be going through the rest of the PDL. It might be like a speed round type of session. So just stick with me. I have the list on this side, so I'm trying to make sure I keep track of all the classes. So the first class that we have is our analgesics, opioid agonist, long acting. And this is where you'll find the morphines, the methadone, the oxycodone ERs, the ER formulations, the fentanyls. So I'm just going to call out really the products that are preferred in this class. And for this one, we have the fentanyl patches. We have morphine sulfate ER tablets, and then we have tramadol HCl ER tablets preferred in that class. Feel free to pause me if I'm going too fast. For the next class, we have our antiemetics, anti-vertigo 5-HT3 receptor antagonists. These are like the granezatron and dazatron palinezatrons. For this class, our preferred products are really all of the ondansetron products, which you can see here. We have solutions, tablets. There's probably some IVs in there, which I can tell by the vial and the syringe, and then the ODTs, or the rapidly disintegrating tablets. So those are preferred without PA. For our anti-vertigo agents other in this class, this is really kind of like a potpourri of different products. So you can see here, there's like the meclizine, doxylamine, prochlorperazine, dronabinol. But for this class, our preferred are, we have Akynzeo, which is, well, that actually, I think that actually goes in the other one. But for this one, we have meclizine tablets preferred. We have the doxylamine pyridoxine, or the vitamin B6. Those are preferred. Then we have Dramamine, which is the brand name meclizine. And then I'm trying to see other ones that I can call out here. We have some metoclopramide tablets preferred, and some prochlorperazine, looks like some vials and tablets. We have some promethazine, some rectals, some suppository syrups, tablets, and we have scopolamine patches preferred, and I think I've called it trimethylbenzamide capsules, and it looks like that's pretty much it. So a lot of meclizine products, depending on the NDC. Those are really the largely preferred products. For our NK1 substance P NK1 receptor antagonists. For this class, our preferred products are, looks like aprepitant capsules, and looks like that's the only product there. For the really NK1 combination class, I think Akinzio was up above. That one, we have Akinzio. That one is non-preferred. There's only one product there. There is PA. And then I'm going to go ahead and skip because this is just all the classes. So getting into our antivirals, hepatitis C agents, we did split up the ribavirins and the Pegasus from the direct-acting antivirals, so that's why you'll see them separate. So really, the only preferred product in our direct-acting antivirals class is Mavorite, and that's because we still have our Hep C elimination program going on and our value-based purchasing agreement for Mavorite. So Mavorite is the only preferred product without PA. If a provider wants to get any of the other Hep C treatments, they will need to request a PA for that other product, really justifying why the patient can't take Mavorite. And then for the other hepatitis C agents, we have the ribavirins preferred. For the non-hormonal, for contraceptives, non-hormonal vaginal, there's one product in that class, it's Phexxi. That is a lactic acid, citric, and potassium gel. This product, it is preferred. I will say that it does say that there is PA, but we are actually actively working on removing the PA on that. That's just a mistake from the old system carrying over. So we will be changing that to be preferred without PA. For the dermatologic gene therapy, we have Vyjuvek. That product we do have preferred. It is there is a PA on that. For the getting into the endocrine and metabolic agents, for the adrenal steroid inhibitors, there's one product in that class, which is Recorlev. That is a levoketoconazole tablet that is preferred with PA. For our testosterone products, for this one, this will be easier for me to call out. Our preferred products in the testosterone classes are, we have various testosterone gels. I do know that we have various strengths. I think there's like the 1.62%, 1%. I believe those are preferred. Unfortunately, you can't see that here in this file, but we do have those preferred. We have gel packets. We have the injectables, so the testosterone cypionate. Those are preferred. We do have PA on all of our testosterone products, and we do have an applicable policy that we do use for that. So that is subject to full PA unless it is being used. There is one caveat for gender dysphoria. We do have those EAs or expedited authorizations that I mentioned earlier today. We do have EAs available for patients that are using testosterone products for gender dysphoria. So they do have that ability of bypassing the PA if it is appropriate for that patient. For the calcimimetic agents, in this class, we just have cinacalcet. We just have the generic preferred, brand name Sensipar is non-preferred. For cortisol synthesis inhibitors, we have brand name Isturisa that is preferred without PA or preferred with PA. That's the only product in that class. For the hereditary tyrosinemia type 1 agents oral, what's preferred there is the generic nitisinone capsules, brand name Nidier tablets, and then we also have brand name Orfadin. All of those pretty much have PA. For the homocystinuria agents oral, the preferred products in this class are betaine powder and uridine triacetate or Zuridine granule packs. For the hyperammonemia agents oral, in this class we do have the Carbaglu preferred, that's brand name, and then the carglumic acid generic non-preferred. This, I will point out, is a rare case where we do prefer the brand over the generic because the brand, surprisingly, is actually more cost-effective than the generic. So that's why you'll see that. That's very far and few between on the PDL, but we do make those types of exceptions. For the, let me get into mineral corticoid receptor antagonist, that one product is Corendia. That is brand name. It's the only product in the class. It's preferred with PA. For the molybdenum cofactor deficiency agents, there's only one product in that class. It's Nulibri. It is preferred with PA as well. And then for the pituitary suppressant combinations, in this class, we have Myfembri and Orion, and both of those products are preferred with PA. For the gastrointestinal agents, live fecal microbiota, there's two products in that class. There's Ray Biota and Voust. So one of them is an enema, one of them is a capsule. We have both preferred Voust or Ray, let me see here. Voust we do have preferred without PA. This one is just included. I believe this is only medically administered, but we do include it in our PDL. That's why you don't see a status here, but we just include it. Then for the hematologic anti-von Willebrand factor agents, there's one product, which is Cablivi, that is preferred with PA. And then getting into our immunosuppressive agents, ROCK inhibitors, there's one product in that class as well, which is Rezurock. It's preferred with PA. I don't know if there's a pattern you can see. A lot of these disease states and classes are kind of more of like the rare disease classes with like the very kind of the higher cost drugs. So typically, if there's only one product in the class, we'll prefer it and add PA just to control utilization, which looks to be the case here. For our migraine agents, our CGRP inhibitors, Luke did kind of allude to this already earlier in the policy, but our preferred products in that class are Aimovig, Ajovy, Emgality, and Ubrelvy. And then for, I'm almost done, it looks like, the ophthalmic agents, or actually, let me go through the 5-HT1. So the triptans here, the preferred triptans that we have in that class are, we have naratriptan tablets, we have rizatriptan tablets, sumatriptan, different formulations. So we have tablet, vial, and then it looks like those are the preferred triptans. And then getting into our ophthalmic agents, alpha adrenergic agonists, there's one product, which is Upneeq, which is oxymetazoline. Looks like it's a dropperette. It is preferred with PA. And then the last classes are the pulmonary hypertension agents. So let me just call out everything that is preferred. We do have an applicable policy that applies to all of these drugs. So they are subject pretty much to PA. But the preferred products are ambrisentan tablets, bosentan tablets, in the endothelin receptor antagonists. For the PDIs, we do have brand name Aleek, which is tadalafil, and then we have some sildenafil tablets as well that are preferred. Then for the prostacyclin receptor agonists, we have Uptravi, that is preferred as well with PA. And then the prostaglandin vasodilators, our preferred products are Tyvaso and Ventavis. And then for the SGC simulators, we have Adempas, which is the only product in the class, and that is preferred as well with PA. So I know I went through that very quickly. Let me know if you want me to go through anything again, but I'll be happy to take any questions from the board.
I was wondering if you think the decision to have even like the really cheapest testosterone still require a PA is something that will ever change? I've never had an issue with Apple Health or Molina, but with United Healthcare, I have a lot of trouble with their form is not great and they don't respond and don't give you any time and all those kinds of things. So I was just wondering um, if that is like a forever decision.
This is Marissa. I don't want to say for sure that that would be a forever decision. Um, I think right now we err more on the side of putting the PA on it just to make sure, because it is, there it is controlled. So we just want to make sure that it's being used for the appropriate uses. So that's why we kind of err on that side, but not to say that there is the possibility that it may or may not be removed. But is it? When you say United Healthcare, it's not like Apple Health, United Healthcare that you're having
The
issues.
community health plan.
Okay. I'm curious.
It's just top of mind because I'm submitting my third version of the PA tonight after I get off this meeting. So
Okay.
it's fine. I would rant over.
No,
Just
it's
it would
fine.
be great to reconsider.
Yeah, no, I'm glad that you did bring that up, because if you are seeing that there are, problems maybe with one particular health plan, as far as like PAs, and this just goes, across the board. We do welcome, any feedback if there's anything that we need to look into on HCA's end, because we can also address if there are any issues with that particular MCO as well. Because if it's not something that you're experiencing across all of them and maybe it's just one, we can definitely look into that, and see if there's any type of resolve that we can get, because there could be some process issues or something, maybe
Yeah, I think there's just some like process issues that they're just really not like incentivized to fix. So, but Peter?
Yeah, I was just gonna say that the other P&T committee I'm on, we got rid of prior auth criteria on the lower cost testosterone products for that reason. Like we found a very low denial rate and still require the PDMP and stuff to get checked. And I think we put quantity limits in there to avoid like really bad abuse type situations. But yeah, we ended up getting rid of it about 2 or 3 years ago for that reason.
Yeah, this is Marissa. I will say, since we did just get a new system, which I guess it wasn't just new, it was 6 months ago. We are considering also, drugs on the PDL that could be good candidates for our smart PA. I think once that's all fixed, maybe that could be a pathway to really alleviate, that need to really like do the full-on clinical PA. It could, alleviate the administrative burden for you all and then also for the clinical reviewers. So we can take that back and take a look. I don't remember. It's honestly been a while since I've looked at the cost of testosterones. So I will take that back to see if how that's looking as far as cost to our program.
Is that then I also want a rule for like all controlled substances that they all have a prior auth?
This is Marissa. Generally, so what I'm thinking of are like the opioids. So I believe the opioids, we have particular like programming that we have that only allow for like acute use and chronic use. But then there's like a limit that they kind of hit. Then it will require PA because we do have like an opioid policy. So we do have kind of PA on that condition. We call them conditional PAs. And then we just removed buprenorphine. I'm trying to think of other controls that we might have.
'Cause,
Yeah.
yeah, and then we just talked about stimulants earlier today too. I mean, the only reason I ask is if that's part of the rationale for having PAs is that testosterone is controlled, whether there are exceptions to that rule.
There are exceptions. I'm sure that there are some on our PDL where we don't necessarily always have PA. Like I think one class that comes to mind, which I'll have to verify, I think are like the benzodiazepines. I believe there probably isn't PA on some of them. There are probably some type of programming limit that we've put, like maybe a quantity limit on those, but I think those might not have PA. And then I'm trying to think of other controlled.
Yeah, I think stimulants too is another great
Yeah,
example. But
stimulants. Yeah, stimulants we do, but I believe that those also hit, there's like specific age dose programming
Sure.
we take into consideration for those. So I don't want to say across the board, like all controlled substances always have PA on them just because they're controlled. But it is something that we do take into consideration, especially if there's like risk of, abuse.
Yeah, and I do see a lot of overprescribing, especially by naturopaths, and so I am also sensitive to that. And so like in Washington, there's a lot of these difficult considerations, right? But it just seems because I think it's relatively inexpensive, maybe one that, could be addressed at some point. Thank you.
Yeah,
So this is Laura. I was curious, can we look back at the opioid section? Because my question here was, I was surprised that, so there's no OxyContin that doesn't require, that's preferred. Is that correct?
This is Marissa. Yeah, it looks like none of the like oxycodone ER products are preferred on our PDL. We have looks like the morphine, sulfate ERs, and the fentanyl patches and tramadol, it looks like.
Do you know the reasoning that there's not an OxyContin product that's preferred?
This is Marissa. So I am not aware of why. And to be quite honest, we have not reviewed or made really any big changes to our opioid classes as far as statuses of the drugs in those classes in quite some time. So I don't know, I can't speak to the history of why a oxycodone ER product was not selected as preferred, but I can take it back to definitely re-review it. We probably are overdue to take a look at these products again. So I think that's a good call out.
And the reason I ask about that is oftentimes there's patients that we stabilize on immediate release oxycodone that then are transitioned even for a short period of time to OxyContin. So it would be not difficult, but you would have to switch them to MS Contin if you want a long acting product.
Yeah, this is Marissa, I'm going to assume that maybe there was some type of cost consideration at the time that we were thinking about the statuses of these drugs. So now that it's 2024, maybe the cost of these, I mean, oxycodone is generic.
Yeah.
There's a significant price difference, but I can definitely take a look at that and see.
Okay.
Yeah.
Okay. Any other questions for Marissa on any of the drug classes we covered today? Okay, and if not, I do know we have a list of stakeholders. So Nani, I'll let you take over for this portion.
Yes, thank you. Okay, let's see here. I am going to go down the list. I know that some people have given their time back to the committee because either it has been covered or they found out their drug is or is um, they've seen the status of the drug class that they're trying to give testimony to. The first person I'm going to call I have here and I'm going to allow to speak is Andrea. And I'm
Sure.
yes.
Good afternoon.
Good afternoon.
Thank you for having me. I'm Andrea Scherschel. I have a PhD in nursing, and I'm a senior medical science liaison with Nestle Health Sciences. And I just had a couple of comments about fecal microbiota spores live BRPK, and then I am available for questions. All right, so VOWST is the first and only orally administered FDA-approved microbiota-based therapeutic comprised of purified firmicute spores designed to reduce recurrent C. difficile infection in adults greater than 18 years of age. The clinical efficacy of VOWST was evaluated in two rigorously clinical trials, ECOSPOR 3 and ECOSPOR 4. Overall recurrence rate in VOWST was 12% compared to 40% in the placebo arm. Most common adverse events following therapy in VOWST-related patients at a rate greater than 5% were all GI in nature and included abdominal distension, fatigue, constipation, chills, and diarrhea. No serious AEs were related to VOWST. Dosage is 4 capsules once a day for 3 days. Following antibacterial therapy and an antibiotic washout. Thank you. I'm available for questions.
Thank you. Any questions for Andrea from the board? Okay.
Okay. Then, oh, sorry. The next was from United Therapeutics, and they gave back their time to the committee. They would not be providing any testimony. The next person I have on my list is Stuart.
Yes, can you hear me? This is Stuart Obrochta.
Yes, I can hear you.
Okay, great. Thank you very much. So I'll answer the questions because I don't think I recently filled out this form. So I work for Gilead Sciences. I'm an executive medical scientist and a pharmacist by training. I am an employee of the company and I do own stock. Thank you very much. I appreciate the opportunity to speak on the hepatitis C class. I am aware of the P&T and the HCA's current decision on HCV therapies, and that Sofvel or Epclusa by brand name is non-preferred. We would ask and hope that this would be reconsidered in the future. But for today, I'd just like to bring up a couple, our one main new information for your consideration as you do consider medical exceptions for this product. So recently at the AASLD, which is the liver meeting in the US, there were a number of abstracts presented on pregnancy, breastfeeding, and mothers. There are currently no approved HCV therapies, including your current preferred agent for pregnancy, breastfeeding, or mothers or infants. The data that I would like to review is from the STORK trial, and I would like to call out, as I just mentioned, there are no approved agents, so Sofvel or Epclusa is not approved either. So I'm not advocating for this, I'm just providing information. So if there is a medical necessity that comes up, you will have this information available. The STORK trial was a trial of 50 pregnant females with chronic hepatitis C treated with Sofvel or Epclusa for 12 weeks. And the results, as I'll bullet point here, was 100% virologic response, so SVR at 12 weeks, no prenatal HCV transmissions, no increased incidence of preterm birth or congenital abnormalities, and no new safety signals related to the drug. So again, this is not an approved indication or an endorsement for Sofvel to be used in this population, but knowing that there are patients that have this potential need, I wanted to provide this data to the committees so that as you evaluate medical exception, that there would be this possibility for patient exception. And again, lastly, I would ask that when the time comes that you would reevaluate this class and reevaluate the agents, and that you would allow for full open access to all pan-genotypic agents in this class. And I thank you for your time, and I would be happy to answer any questions.
Thank you, Stuart. Questions from the committee for Stuart? Okay.
Okay, and next on the list is Christine. And Christine, you did complete the conflict of interest, so you do not need to answer the question on the screen.
Yes, thank you, everyone. I'm Kristen Hart. I'm a medical science liaison with Recordati Rare Diseases, covering our endocrinology rare disease therapeutic area. And I would just like to thank the committee very much for the consideration in addition to my written testimony today for Isturisa or osilodrostat as a cortisol synthesis inhibitor. Thank you so much for considering the request. Thank you for making it a preferred agent, and I cede the rest of my time.
Thank you, Kristen.
And the next on the list is Erin. Erin, you completed the conflict of interest, so you do not need to answer the question on the screen.
Great, thank you. Hello, my name is Erin Novak, Medical Outcomes and Science Liaison with Medical Affairs at AbbVie. Thank you for allowing me a few minutes to speak on glecaprevir, pibrentasvir, or Mavyret. I acknowledge the committee has already reviewed Mavyret in detail and that it's on the PDL, so thank you. My goal in providing comment today is just to reassure the committee that this covers the vast majority of HCV-infected individuals at over 98% of the population. It's a once daily pangenotypic ribavirin-free regimen that can treat all treatment-naive patients with compensated cirrhosis or without cirrhosis in only 8 weeks. This may positively impact adherence, and it is a significant improvement over other therapies that require 12 or more weeks of treatment. Relative to safety, Mavyret does carry the DAA class-wide box warning regarding the risk of hepatitis B reactivation in patients co-infected with HCV and VV. Mavyret is contraindicated in patients with moderate or severe hepatic impairment or those who have a history of prior hepatic decompensation, and also for those taking concomitant atazanavir or rifampin. More information on that can be found in the prescribing information at rxabbvie.com. But overall, Mavyret has attributes that patients would prefer to therapy, particularly that 8-week treatment duration, allowing patients overall to spend less time managing their disease. Given that Mavyret is appropriate for the vast majority of HCV-infected individuals, the state of Washington has made a strong treatment choice as the preferred therapy for the patient population. Thank you for your time, and I just wanted to let you know that I'm available for any questions you may have regarding Mavyret. Thank you.
Thank you, Erin. Any questions for Erin from the board? All right.
Okay. Next I had on the list was Karen Ward from Crystal Biotech. I do not see Karen here, but I do see Andy, and I don't know from Crystal Biotech, and I'm not sure if they wanted to give a testimony. Andy, if you want to, you can unmute yourself. Okay. Next was Nicole Tran. I do not see Nicole on the call, but I do see Mike. Mike, I do not know if you wanted to give a testimony. If you do, go ahead, unmute yourself.
Thank you. I think we can cede back the rest of our time. Nicole had seen your review of Carbaglu prior to the presentation. So thank you very much
Okay,
to the committee
perfect.
for your consideration. Bye now.
Bye, thank you. And Rochelle conceded her time back. She's already given her testimony, so I think that is it. I do not see any other hands raised. Oh, I just saw one right now.
Okay.
Okay. I do not want to say your name incorrectly, but go ahead and read the questions on the answer the questions on the screen.
Thanks, Nanye. Hopefully everyone can hear me.
Yes.
My name is Nirmal Guman, and I'm speaking on behalf of Johnson & Johnson Innovative Medicine. I had filled out the stakeholder conflict of interest form, but happy to answer the questions here. I'm representing J&J, and I am an employee of J&J. And again, hi, my name is Nirmal Guman, and I'm a pharmacist and principal scientific account lead with Johnson & Johnson Innovative Medicine. Thank you for the opportunity to speak to you about Opsynvi. Opsynvi is a combination of macitentan and endothelin receptor antagonist, and tadalafil, a phosphodiesterase 5 inhibitor indicated for chronic treatment of pulmonary arterial hypertension in adult patients of WHO functional class 2 and 3. Individually, macitentan reduces the risk of clinical worsening events and hospitalization, and tadalafil improves exercise ability. Please refer to the full prescribing information for complete information. We are thankful to have been able to provide input at the October meeting and would appreciate the addition of option B to the PAH criteria set. I otherwise yield the remainder of my time and am available for any questions. Thank you.
Thank you, Nirmal. Questions from the board? Okay. Any other stakeholders, Nanya?
No, I do not see any other hands raised. Thank you.
All right, great. Should we have a look at the motions? And yes, I'll have all our board members back on camera, please.
I can read it. Oh, sorry.
Okay.
I
wanted
move
it?
that I got it. Zoe Taylor. I move that all products in the drug classes listed on slides 7, 8, 9, 10, and 11 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products of the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Laura Bestie. I second the motion.
All in favor, please say aye.
Aye.
Any opposed or abstain? Okay, with that, the motion carries. And I think that brings us to the conclusion of today's meeting, Nanya.
Yes, it does.
Adjourn the DUR board, and this time for reals, goodbye. Thank you, board.
Thank you
Thank
so much,
you.
Kavita,
Thank you.
for
Kavita.
your work. Yeah, thank you.
Yeah, thank you.
Right, happy holidays.
Yeah, happy holidays. Bye.
Bye, everyone. Thank you, guys. Thank you, everyone. Thank you guys so much for working with our schedule, with the schedule change. I really appreciate it. Thank you.
Yeah.
No problem.
Bye.
Bye.